Hello and welcome to day one of our two-day virtual public meeting, where we have gathered a number of speakers to help understand the current landscape of fatal overdoses in the United States and thus inform product development and public health interventions. I am Susan Winkler, and I have the honor of serving as the Chief Executive Officer for the Reagan-Udall Foundation for the FDA. We're pleased to be working with the U.S. Food and Drug Administration to be hosting this virtual event both today and tomorrow. So before we get into the substance, I will address a few housekeeping items. Because of the size of the meeting, attendee cameras and microphones will remain off throughout the event. As mentioned, we have a fantastic lineup of speakers and panels. We may have a few moments in each session to address audience questions, and so I invite you to submit your questions and comments through the Q&A function. We are recording the meeting and plan to post the recording along with the slide deck and transcript on the FDA Foundation website later this week. So allow me to orient you to our time together both today and tomorrow. In just a moment, I will turn the podium over to FDA Commissioner Dr. Robert Califf, who will kick us off with some opening remarks. After that, we have three sessions with a mix of presentations and panel discussions to explore topics ranging from recent public health trends related to overdose, the pharmacology of fentanyl and naloxone, and real-world experiences with managing overdose. Then we'll let you go and we'll come back tomorrow, where we will pick back up at the same time to explore novel approaches to preventing overdose deaths and considerations for medical product development. The full agenda is available on the FDA Foundation website, and the link is, or shortly will be, posted in the chat. So I want to first confirm whether we've had the opportunity for Commissioner Califf to join us yet. And I don't see that he has joined us, so we are going to give that one more minute, and if not, then we're going to jump right into our sessions because we have quite a lot of content to cover today, and I can assure you that one of the things that happens when you are the commissioner at the FDA is that your schedule is no longer your own, and that things can emerge at the last minute to disrupt availability. So give it a little bit more, and if we don't have that, we will go ahead and get started. All right, I knew we waited just the right amount of time for the commissioner to join us. And so with that, I will repeat my introduction and say that we are thrilled to have joining us to provide some opening remarks for this important meeting, Dr. Robert Califf, who serves as the commissioner at the FDA. And so team, let me know if we're ready to turn it over to Commissioner Califf. It's one of those dynamics. There you are. Commissioner Califf, welcome. We've got some time on the agenda to hear from you, and so I'm going to go ahead and step out of the way and let you pick up and take it away.
Hey, thanks a bunch, and sorry that I'm a bit late here. We got a lot going on today, but it's really good to be with you and also with this important meeting. I do want to thank Reagan-Udall. You guys are doing a lot of work with us right now, everything from tobacco to food to this important topic. I also want to thank the speakers. And in fact, I'm sort of not happy being the commissioner today because looking at the agenda, I'm sure that these talks are going to be fantastic and give us a lot of good ideas, but I'll be pestering people for slides and make sure that I get caught up over the course of the next couple of days. I think we all, I won't bore you with the statistics. You all know the statistics. We have a lot of work to do. Things are not necessarily headed in the right direction at this point. I did have a chance last night to tune in to Anderson Cooper's special on fentanyl, featuring an interesting discussion with Ann Milgram, the DEA administrator, that went into some of the more personal aspects of the battle that we're all engaged in here to reverse the tide in overdoses. We're all aware of the impact this has, not only on the individuals, but the families and the communities that are involved. And I personally got to learn a lot about it with the not-for-profit in Dayton, Ohio that we started in between my times as commissioner, and really got a deep feeling for the amount of intersection there is across all the domains that we think about for human health, the biological, the clinical, the social, the legal. All these things come into play, culminating in outcomes that we need to work together to prevent. So in light of that, just a quick word about our overdose prevention framework, which we've now published. It's consistent with the Department of Health and Human Services strategy, and that's aligned with the National Drug Control Strategy. So hopefully the degree to which we're aligned will begin to produce greater and greater traction as we deal with these issues. Our four big priorities: prevention, harm reduction, evidence-based treatment, and assuring the supply of the right medications. Under the harm reduction priority, we're working with a focus on reducing morbidity and mortality from overdoses. Therefore, this meeting is really an important one, and we all recognize that naloxone is a critical part of that effort. And, you know, I had the chance to use naloxone every once in a while as a practicing intensive care cardiologist, as we treated people with pulmonary edema and heart attacks and other painful conditions. I have a great respect for its effectiveness. And in fact, as time has gone on, I increasingly see it like external cardiac defibrillators, which we've made a great effort to put everywhere. I think the same is true with naloxone. I think a large part of the American population got a sense for the difference it makes when you have a life-saving treatment available. When Mr. Hamlin, the Buffalo Bills player, had sudden death on the football field and was promptly resuscitated. And we need to be able to replicate that across the board for people that are overdosed. So it's important that we engage with people across the board in this effort, including meetings like this. And the feedback that we get really does inform our actions. And I want to assure everyone that we are working on this every day. In a changing situation that we're in, we have to adjust what we're working on, and these kinds of meetings are absolutely critical. Just as an example, it was about a year ago that we had the virtual public meeting with the Reagan-Udall Foundation focusing on naloxone access. There was pretty much a unanimous chorus that we needed to get on the stick to make naloxone more available. Last September, we put an immediately in effect guidance out clarifying the scope of the public health emergency exclusion and exemption from the Drug Supply Chain Security Act as they apply to the distribution of FDA-approved naloxone products directly to harm reduction programs. So that was a good example, I think, of action taken based on feedback that we received. And I do believe this guidance is having an impact, but it's only one part of a much larger picture that we need to continue to work on. And last November, we partnered with SAMHSA to speak with harm reduction groups and other stakeholders and emphasize there that we're going to do what we can to support harm reduction programs as they try to obtain FDA-approved naloxone products. Now, we've also been working on non-prescription naloxone, we've heard a lot of calls to make that happen, and it was a hot topic at Anderson Cooper's discussion last night. And we've taken a proactive regulatory approach now to this issue. Last November, we issued a Federal Register notice and announced our preliminary assessment that certain naloxone products may be approvable as safe and effective for non-prescription use. This was meant to really stimulate the field to move along. And just last month, we had an advisory committee meeting that discussed a supplement to Narcan nasal sprays application to switch to the product from prescription to non-prescription. There was a really very broad agreement that this is a good thing to do with a unanimous vote. Feel a little odd saying vote because I'm publicly saying we need to have less votes in advisory committee meetings and more attention to the thinking that goes behind the way people derive their conclusions about the products that we're regulating. But anyway, this advisory committee meeting was I think, a very successful meeting with a clear mandate to move ahead. Also in February, Reagan-Udall published a white paper on an exploratory analysis describing some of the distribution channels for naloxone. And I think a lot of people learned a lot from this, including me, about the extent to which non-traditional patterns of distribution are now in effect. So also just to point out that we are aware that transition from prescription to non-prescription can lead to unintended consequences for some people, particularly if it changes the degree to which insurance covers the availability of the product. And we're working closely with other HHS agencies to make sure, and departments to make sure that we are able to respond to any difficulties that may arise in the market as this happens. So with that, it's time to get on with the meeting today. This is just a preamble. I think the really interesting talks and ideas are going to be essential to our future. Given that there are so many fatal overdoses, we've got a lot of questions. How can we assure that the products are currently available, can effectively meet public health needs? We've got this polysubstance issue becoming more and more prevalent with xylazine, for example, in a very high proportion of the products that people are using. What are the obstacles that make the development, approval, and real-world use of these products challenging, and how can we address them? This is always a balance that we have at FDA. How do we enable things to move faster, but also protect the public from ineffective or unsafe products? So the collective experience of the people in this meeting and other meetings that we have are essential for us. We need to know which interventions are being used in the field and how, and what the problems are as they're used, so that we can expand access to life-saving interventions in a safe way. And we need to continue to encourage innovation, both in the addressing the overdose issue, but also in the broader context of treating pain. This is an area where, personally, I feel like we haven't reached the point that we need to in terms of new ideas coming through. So new ideas are welcome. So I hope these questions and the comments are useful as you have your meeting. Let's think about what more we can do to prevent fatal overdoses. And let's think about how we can better use the products we have and what other products we may need. None of us can handle this alone. We've got to work together, hopefully to create a world in which no overdose is fatal. So I look forward to hearing the ideas and how we can put them into action. Thanks, and please have a great meeting.
Fabulous. Thank you so much, Commissioner Califf, for opening us with the right reminder about how important it is for the agency to hear from the community, the multifaceted challenges that we're facing, and the opportunity to make a difference. I think we'll probably have more slides than they did on Anderson Cooper, but we will try to be just as informative in our sessions today. Thanks so much for joining us. And with that, we're going to turn to our first set of presenters who will provide insight on the current landscape of drug use and overdose in the United States. I am going to turn first to Dr. Chris Jones. So please join us on screen to provide your presentation. Dr. Jones is the director of the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. Dr. Jones, I'm going to step out of the way and let you step up to the microphone. You're still muted.
Yep, sorry, I was trying to find the button. Really appreciate the opportunity, and obviously this is a complex issue. My hope today with my short talk is to just set the table a little bit about current trends in the overdose crisis, where we are now with the latest data, which I think is really important as we think about what solutions are needed to address the challenges that we're facing. So first, just a very macro perspective on the current state of the overdose crisis. And this is a slide that captures drug overdose death rates in the United States from 1968 to 2021, which is the latest data that we have final mortality available at the national level from CDC. And you can see here that generally since even the mid to early 1980s, there has been a rise in overdose deaths. The particular drugs that have contributed to overdose have changed over time, but we have been in an upward trajectory. And in some years, that trajectory has been more steep than others. And in the last couple of years in particular, moving into the COVID-19 pandemic, we have seen large and historic increases year over year in overdose deaths. And you can see the highest rate that we have tracked over this time period is in 2021. And in that time period, over 106,000 lives were lost to overdose in 2021. This slide just looks at it from a state level, and I think it underscores that not everybody is experiencing the exact same challenge, that there is wide variation in overdose death rates by state. Some are lower than the national rate, and others are substantially higher than the national rate for overdose deaths. And this just provides a little bit of a more granular picture over time. These are county level overdose deaths. And again, I think it just underscores the point that generally everybody has experienced some level of increase over this time period, but some certainly more than others, and that there are geographic differences in overdose deaths when we look at the county level. Some have substantially higher rates. Those are the darker red areas compared to the lighter gray or white areas. And I just wanted to provide some of the latest provisional data from CDC that looks at the first half of 2022 compared to where we've been month by month over the last couple of years. And you see here that in 2018, there was a small decline in overdose deaths, and that decline really happened in the latter part of 2018. In 2019, even before COVID-19 hit, really in that last 6 or 7 months of 2019, you started to see an increase in overdose deaths, and that obviously substantially increased during COVID, with a particular rapid increase in the first few months of COVID-19 that subsided somewhat. But as you can see, the curve has shifted up over time, and that carried into 2021, where essentially in every month in 2021, overdose deaths were higher than 2020, except for May of 2020. The red line here represents provisional data for 2022 from January through July. And again, these are not complete and final data. The numbers are likely to change. They may go up as more data come into CDC from jurisdictions and death certificates. But you can see here in the last few months of 2020 that we have data, the number of overdose deaths has been lower than what we saw in 2021. But again, the latter part of the year is often an important time where we'll see where things are going. So I think it is certainly too early to say we have a downward trajectory, but it does appear that the large historic increases that we were seeing in 2020 and 2021 are not being repeated in 2022 so far, but certainly 2022 is much higher than we saw pre-COVID levels in 2018 and 2019. Right. And looking just a little bit at the demographic data, and I'm not going to go into this in any great detail, but just to make the point that really across all demographic groups, regardless of how we cut those data, race, ethnicity, age, urbanization, or gender, that there has been an increase in overdose deaths among those populations. One thing I will highlight related to race, ethnicity, is that we have seen a shift over the last few years where rates among non-Hispanic American Indian Alaska Native populations and non-Hispanic Black populations have risen beyond those for non-Hispanic white populations. So there was a shift in which groups had the highest rates. And we have documented those increases in other research from CDC. And I think an important shift in demographic impact, and as we think about solutions, making sure that we're thinking about disparities in health equity as a part of those solutions. And one other point I wanted to make, when we look at drug overdose deaths, a lot of the focus has been on opioids, rightfully so, in particular synthetic opioids like illicitly made fentanyl. But when you look at overdose deaths overall, most deaths involve more than one drug. And so as the commissioner mentioned, polysubstance use, underlying substance use and addiction are really what is driving much of what we see here. And I just put up several major classes of substances to give some perspective on how often different psychoactive substances are involved in overdose deaths. And you can see here, again, by and large, synthetic opioids are the most common group of drugs that are involved. And we've seen less and less involvement from things like heroin or natural semi-synthetic opioids, which are typically the prescription opioid analgesic group, as well as declines in methadone. Whereas in more recent years, we've seen increases in psychostimulants, which is largely methamphetamine here, as well as cocaine, some drop in benzodiazepine involvement in overdose deaths. And there is an overall code in the ICD-10 coding system for mortality data where xylazine is included, T42.7. And you can see here that T code has increasingly shown up in overdose deaths as well, consistent with what we're seeing in other data around the emergence of xylazine in the illicit drug supply. From another data source that CDC has called SUITRS, which is the State Unintentional Drug Overdose Reporting System, looking at data in 32 states, we're able to look a bit more granular of the particular types of substances involved in overdose deaths. And we see here that, again, opioids and stimulants are the predominant classes of drugs that are involved in overdose deaths. And in fact, less than 4% of overdose deaths in 2021 in these 32 states were deaths that involved neither opioids or stimulants. But we continue to see illicitly manufactured fentanyls as a predominant group of substances that show up in overdose deaths, as well as things like methamphetamine and cocaine, and then combinations of those substances as outlined here. And another data point that I thought was worth raising in the context of this meeting is, where do people die? And this comes from death certificate data from the National Vital Statistics System, but we see that about half of individuals die in their home. Another large minority die in some sort of medical facility, whether it's an inpatient or outpatient facility. But when we think about naloxone access, bystander interventions to reduce overdose, thinking about half of people who die in their home is an important consideration as we think about what solutions are needed to address these challenges. And then the last slide is just one that I thought was important to underscore, that we talk a lot about data and statistics, but certainly there are individuals and families and communities who underlie all of those data. And when we look at particular ages, the burden of overdose is not evenly distributed across ages. And this just looks at the proportion of deaths. Why do people die? And what proportion or percent of those deaths were due to drug overdose? And you see here in the 15 to 44-year-old age group that more than 1 in 5, 1 in 4 die from overdose. Of all the other causes that they die of. And when we look in particular at 25 to 34-year-olds, it's almost 1 in 3 die from a drug overdose. And again, as we think about who is impacted, what solutions are needed, just underscoring the burden and magnitude of this challenge, in particular among younger populations, is particularly important. So looking specifically at opioids, again, I'm not going to repeat what I've already shared in the overall drug overdose data, but again, we do see increases, and we also see demographic shifts in opioid-involved overdose deaths. And similarly, when we look at what particular drugs are involved in opioid-involved overdose deaths, again, other drugs beyond opioids are commonly involved in these deaths. And again, synthetic opioids like illicitly made fentanyl are the predominant opioid that are driving overdose deaths. But we also see more than a quarter involve psychostimulants or cocaine. And as I mentioned, the xylazine related T code increasingly is showing up, about 5.6% in the provisional data for 2022. And just a couple of comments I wanted to make on stimulants. There has been great interest in resurgent stimulant use and harms in the US, in particular methamphetamine. When we look at death certificate data, methamphetamine is lumped into a larger category of psychostimulants with abuse potential. But by and large, the deaths that are in this category do involve methamphetamine. And I think it's important as we think about, again, solutions to these challenges to recognize that sort of a one-drug approach is not likely to be successful, that we really have to think about polysubstance use, what other substances that people are using that can increase their risk. And so as we look at the trend for psychostimulants, we see that there has been an increase in psychostimulant-involved overdose deaths with or without opioids. But really, in more recent years, the rate of rise for psychostimulant deaths with opioids has eclipsed that without opioids, and the percent has been increasing over time. It's about 67% when we look at the provisional data for 2022. When we look at cocaine, the other primary stimulant of interest, we see that the story is a little bit different, that really the rise in cocaine-involved overdose deaths has happened in parallel with overdose deaths that involve both cocaine as well as opioids. And the trend line for cocaine-involved overdose deaths without opioids is much flatter, although some increase in recent years. But in the provisional data for 2022 so far, about 78% of cocaine-involved overdose deaths also involved opioids. And certainly the trends that we're seeing in mortality and other substance use patterns are related to what's happening in the supply. And we continue to see record levels of synthetic opioids in the illicit drug supply, fentanyl analogs, novel synthetic opioids that are not built on the fentanyl structure, nitazines, other synthetic opioids showing up. But we also see historic levels of methamphetamine in the US, the proliferation of counterfeit pills that have pressed fentanyl or fentanyl analogs in them, and in some cases even pressed pharmaceuticals that have methamphetamine that are made to look like commonly misused stimulants like Adderall. And I think the proliferation of counterfeit pills in particular has enabled really broad reach of highly potent, unpredictable illicit drugs into communities across the country. And it is that lethality and unpredictability in what are you actually using and do you know what you're using that certainly has contributed to a much greater rise in overdose deaths compared to, say, changes in substance use patterns, which have changed some, but certainly not to the degree that we have seen with mortality data. And just a little bit more on the supply side, this is from DEA's latest National Forensic Lab Information System data, NIFLS data, which looks at drugs that are confiscated or part of different law enforcement cases. And you can see here that things like fentanyl, methamphetamine have been increasing over time, consistent with what we see in the health-related data as well, whereas other substances like alprazolam or oxycodone have been going down over time, which again is generally consistent with the mortality data and other health data sources. So that is it for me. Let me just briefly say that we continue to see the overdose crisis dominated by illicit synthetic opioids, but that most overdose deaths do involve other drugs, and in particular, the rising co-use of stimulants and opioids and changing patterns of use for people who are using both opioids and stimulants, including increasing reports of injection of those substances, adds risk and concern to the current environment in which we're operating in. We have seen a westward expansion of illicit fentanyl and analogs, which has contributed to large increases in overdose deaths in westward states, and an eastward expansion of methamphetamine into illicit drug markets that historically did not have methamphetamine. And we're now seeing in health-related data the impacts of that change in supply. I've already talked about the challenges with counterfeit pills, and that this really unpredictable and highly potent market is contributing to health harms among communities across the country. So thinking about this in a holistic way, not drug by drug, I think is really critical as we approach these efforts together. So thanks very much for the opportunity to present.
Dr. Jones, thank you so much for giving us that stage setting way of thinking about the population that is affected, as well as some insight into just what we're seeing on the trends there. I'll note for our audience, we understand that there is a bit of a challenge with the audio, and we are actively working on that. The good news is that the recording should be very clear. Unfortunately, that's not good news for you in the moment, but we are working on that transmission piece. I'm now going to turn to our second speaker, who is Dr. Angela Husky, Senior Vice President and Chief Clinical Officer for Millennium Health, an accredited specialty laboratory with expertise in clinical drug testing and drug use trends data. Angela, I know you're ready, and I'm going to turn it to you to lead us through your information.
Thank you, Susan, and good afternoon, everyone. I want to first thank Reagan-Udall for having me here today. It's such an honor to be part of this session with two presenters, Dr. Jones, who you just heard, and Dr. Wish, who you'll hear next, who, along with their colleagues, have worked so tirelessly to address the drug overdose crisis. Sharing vital information to help reduce overdose deaths is also a key tenet for my team, using our database of drug test results, which I'm going to share some of with you today. As my colleagues and I worked over the past several years to develop methods by which information from drug testing could be used to describe and monitor the current dangerous drug use trends, we knew one thing: the speed with which this data could inform was unique. And as we obtained thousands of new real-time data points each day, telling the story of current drug use, and combined with the many other sources of surveillance like we're seeing today, one should feel very confident that we can have a clear picture of the present danger and we can act decisively against it. I'm grateful to play a part in bringing awareness and collaborating with all of you who are working to put an end to overdose fatalities. My colleagues and I at Millennium Health will continue to devote our testing, our data, our people to combat the overdose crisis, and we pledge to never become desensitized to or accept as normal the loss of 100,000 of our fellow citizens in a year to drug overdose. Today, I want to mention that I also hope we think about and appreciate the loss of life represents a fraction of the consequences. The pain suffered by people and families living with substance use is also enormous. Like many listening today, I know firsthand the family-related challenges and heartaches of living among a loved one with substance use. So I certainly hope the information here is informative and that it will ultimately make a difference in lives, families, and communities across the nation. Just a little bit of background to set the stage. See, I'm not advancing. Oh. There we go. Just a little bit of background to set the stage. The data in my presentation today comes from Volume 5 of the Millennium Health Signals Report, which was released earlier this year. This is part of a larger drug trend surveillance program at Millennium named the Emerging Threats Intelligence Program for Drug Use. The report, providing the specific data we are discussing today, is a focus on fentanyl and polysubstance use, a timely topic for this meeting. The report includes an evaluation of drug test results from more than 4.5 million specimens, over 600,000 unique patients in all 50 states, all receiving care for a substance use disorder. The report includes very current data as well through the end of 2022, and our larger surveillance program is analyzing and monitoring data as current as this week in other formats. Additional demographics about the data I'm discussing today are on the slide, and I've prepared just some brief highlights from each section of the report. More can be found in the full report, and I do believe they're going to link that in the chat at some point. So as you look at the data that I'm presenting today, you may ask yourself how these trends, the drug use trends, measure to the greatest interest of you, which is the overdose death data Chris just presented. It's a fair question. We asked it ourselves, and together with researchers at OSU, we answered that question. The study shown here and published in JAMA Network Open analyzed the relationship between urine drug test results, the database I work from, and overdose mortality obtained from CDC's Wonder. Overall, we found the strongest relationship to overdose deaths observed for urine drug test results of synthetic opioids. Shown on the graph on the slide, the two significantly correlated over time with a Spearman R of 0.96, and the study found that urine drug test results may be an early indicator to what is to come in terms of overdose mortality. With this foundation laid, we're now working on overdose prediction models and hope to have those available soon to groups like Reagan-Udall to help make decisions. As you've heard today from Chris, and we'll also hear from others, synthetic opioids, primarily illicitly manufactured fentanyl, are the driving force behind the current overdose crisis in the US, contributing to more than 65% of all drug overdose deaths last year. And you've heard already that fentanyl is not the sole problem. As Chris stated, we need to think about this holistically. Having said that, I'm starting here with an image of an analysis individually for the 5 drugs and drug classes that have historically driven overdose deaths. But in later slides, I'll move into the more real-world picture of polysubstance use, as most fatal overdoses you just heard involve more than one substance, complicating treatment strategies as well as life-saving interventions. Graphed here is drug use based on urine drug test positivity over time. The blue and red lines are primarily why we are here today, significant rises in fentanyl and methamphetamine. In 2022, fentanyl was the most detected drug in samples coming to our lab from this population. The light blue line depicts that fentanyl is detected in about 10% of all of those specimens. The close second is methamphetamine in red, and as you know and have heard, both have risen sharply since 2019. While positivity for illicit use of prescription opioids, that's the purple line, is falling and has decreased nationally by about 50% compared to 2015, it's still the third most frequently detected class of drugs. Cocaine remains positive in around about 4 to 6% of specimens, but as you're going to hear later in this presentation, it is detected more and more along with fentanyl, and thus more dangerous. Heroin positivity is lowest, around 1%, but almost always with fentanyl, as you'll see in a later slide. Just a really quick brief mention regarding the downturn you see for all substances in 2022. This decrease is seen nationally, but not necessarily the case in every state. It's consistent with what we're seeing in the preliminary overdose death data that Chris showed from 2022. We're certainly hopeful and cautiously optimistic that this downturn will continue and will equate to less overdose deaths. Chris also mentioned the westward expansion of fentanyl, and this is shown here in our data. Fentanyl use was significantly higher nationally in 2022 compared to 2019. We know that already. From the map, you can see since 2019, drug test positive for fentanyl increased 146% nationally and increased in every US Census division. Additionally, detection of fentanyl was the highest in the South Atlantic and mountain regions in 2022, while the largest increases during this time in fentanyl occurred in the Pacific and mountain regions, where you can see that the fentanyl positive test increased by over 875% in the West. The full report does have a geographical analysis of numerous other drugs and drug classes. I'm going to show 2 more just quickly here. Shown here is methamphetamine, which was also significantly higher nationally in 2022 compared to 2019, with the highest positivity in the eastern half of the US. You also heard that from Chris, the eastward expansion of methamphetamine, and the largest increases were seen in the South Atlantic and mountain divisions. During this time, drug test positive for methamphetamine increased about 40% nationally, but also increased in 6 of the 9 US Census divisions. Illicit use of prescription opioids, we've seen this theme. Our data mirrors the same, declined significantly nationally. You also saw that on the first graph, between 2019 and 2022 test positive for the illicit use of prescription opioids decreased by about 20% nationally, but you can see a little bit of geographic variation in that number. While the overdose crisis is fueled primarily by illicitly manufactured fentanyl, what you've heard and will today over and over is that most overdose deaths involve a combination of drugs. The next few slides will help us to look at a more holistic picture of current drug use. The image here focuses on an analysis of fentanyl found in a population of people using heroin, prescription opioids, methamphetamine, and cocaine. These results may reflect intentional co-use or even the more dangerous scenario of the person unknowingly using tainted drug supplies or counterfeit pills. The DEA laboratory testing, the latest DEA laboratory testing reveals that 6 out of 10 fentanyl-laced fake prescription pills now contain a potentially lethal dose of fentanyl. So let's take a quick look here. If you look at the green line on top, fentanyl is now detected in over 95% of samples positive for heroin, suggesting that it is unlikely or rare a person could obtain a fentanyl-free batch of heroin. We know drug traffickers prefer fentanyl over heroin because of its potency, concealability, profitability, so this really isn't too surprising. The next line down, which is the purple line, shows that about 2/3 of those illicitly using and positive for prescription opioids are also positive for fentanyl, and about half of the population using and positive for methamphetamine or cocaine are also positive for fentanyl. That's the red and yellow lines. This finding is consistent with data suggesting that stimulants in fentanyl are increasingly co-involved in fatal overdoses. And we saw that in Dr. Jones's slides. Fentanyl analogs are increasingly important players in the polysubstance use story. Chris mentioned the concern for these agents in his presentation. Fentanyl analogs are often combined with fentanyl. They've been linked to overdose fatalities themselves, and they may further complicate life-saving efforts. Fentanyl analogs refers to an evolving subclass of synthetic opioids with a chemical structure like fentanyl, and so as a result, they produce effects like fentanyl, but the strength and potency of each different varying fentanyl analog can vary significantly. Fentanyl, as you may know, is 50 to 100 times more potent than morphine, but one fentanyl analog, for example, carfentanil, is 100 times more potent than fentanyl, so 10,000 times more potent than morphine. Our data indicate that fentanyl use is rarely just fentanyl. Over 60% of specimens positive for fentanyl also tested positive for one or more of the analogs. So when you think about a supply of drugs that not only has the potency of fentanyl, but also compound that with one or more analogs, you can start to see the real danger and unpredictability. Additionally, there are striking geographical differences in where each analog is more prevalent, and this, of course, may have important clinical implications. Increased awareness regarding specific fentanyl analogs and where they are can obviously create a better opportunity for better outcomes. There are a lot of layers to this and complexity, but some questions that we may want to ask ourselves related to the analogs are listed here. Will naloxone be as effective in an individual in one region versus another if there are fentanyl analogs present or differing fentanyl analogs? Do fentanyl test strips fully capture the presence and significance of fentanyl analogs? And does an individual entering treatment in Georgia, per se, require a different buprenorphine initiation strategy than someone in Montana? Just some things that we may not have all the answers to, but something to consider with regards to these agents. You've heard this already, but I just think it's super important to stress, rarely does the data reflect single substance use. The data on this slide is very timely. It reflects an analysis just from the late part of 2022. Starting with fentanyl positive specimens, we asked ourselves, what else are those who use fentanyl taking, maybe knowingly or unknowingly, in their supplies? What we see here is a lot of dangerous combinations. Methamphetamine and cannabis were the second and third most detected substances in a population positive for fentanyl, with almost half also positive for methamphetamine and about 40% testing positive for cannabis. In addition to the risk that fentanyl poses, with the potency of methamphetamine and cannabis today, the effects of polysubstance use, of course, are even greater. Prescription opioids were found in more than 1 in 4 specimens. also positive for fentanyl, and cocaine was detected in more than 1 in 5. Approximately 13% of the population positive for fentanyl was also positive for gabapentin, and about 10% also positive for benzodiazepine or alcohol. This is a picture of just some select analytes that we see in the polysubstance use picture. There are many more dangerous combinations found, more and more showing up on the market regularly, and we are following them closely in real time. There just wasn't enough time today to talk about them all. As we continue the polysubstance use story, one important stat that came out of this data in this report is that over 80% of specimens testing positive for fentanyl were also positive for more than just fentanyl. About 30% of them had 1 or more additional drugs. About 40% of them had 2 or 3 additional drugs. And about 10% of them had 4 or more additional drugs. The most common combinations we saw in that are pictured here on the slide. Just as a note for this slide, as well as the data on the last slide, the results of our testing don't tell us how the substances ended up together in the specimen, whether that is something that was fentanyl laced versus sequential or overlapping use, but only that they had been used at least in close enough time to test positive together. And I think that's an important takeaway here. From the slide, you can see that cannabis and fentanyl were the most common combination. Meth and cocaine were second and third most commonly co-detected drugs with fentanyl. Fentanyl, cannabis, and a stimulant were next, and you can see so on the slide. Lastly, I want to share just a visual that shows how polysubstance use patterns vary geographically as we're talking about solutions and differing solutions that may need to be implemented geographically. This certainly suggests and supports that treatment strategies and community response efforts may need to be tailored. The graph here illustrates the proportion of fentanyl-positive specimens that were also positive for other substances, and it's showing a comparison of national rates to 4 specific states kind of spread out in different regions. Some of the patterns here I think are super surprising, even to me and my colleagues who do this work, and support that more targeted evaluation and approach to solutions may help us to have better outcomes. Just as one example, if you look at Virginia, which is the red lines, and Montana, which are the purple lines, the patterns are completely reversed. Among those using fentanyl, more also use methamphetamine in Montana compared to Virginia by 3-fold. But the opposite is true for prescription opioids and cocaine. There's a lot of interesting patterns here, and they're described in more detail in the full report. Note, we also frequently do this exact type of analysis within a state, and we can see large variations even from county to county. In conclusion, just a few remarks. We've shown that fentanyl and methamphetamine were the top drugs found among those in this analysis in 2022. We saw that slight downward shift in positivity for all drugs and drug classes in 2022, consistent with the preliminary overdose death data. We certainly hope this continues. Even with the downward overall positivity for individual drugs, we're seeing this sharp increase in co-positivity of fentanyl with other drugs, as well as just a larger picture of polysubstance use. And this may support a focus on treatment and interventions tailored to be effective for polysubstance use. Obviously, we are all here today because we believe it is important to maintain awareness and take action. Keeping in mind geographical trends may help us to improve our approaches. With that, I thank you and turn it back over to Susan.
Angela, thank you for those powerful images and data. I'm still kind of keyed in on the geographic differences as well as the polysubstance piece. So thank you for that great addition to the data provided by Dr. Jones. I'll note as we turn to our third presentation in this space, where we will be hearing from Dr. Eric Wish, who is the former director of the Center for Substance Abuse Research at the University of Maryland. Dr. Wish, if you want to come to the stage, and I'll remind our participants, we are making progress on that audio challenge, and I understand it's getting a bit better. We're going to keep working on it and continue to improve it. Just imagine it's as if you were in a meeting room and the room next door was a little loud. We're doing our best to quiet down that activity. And Dr. Wish, we are ready for you.
All right. Well, I'm ready for you too. Thank you. I've just enjoyed listening to the prior presentations, and I'm really kind of amazed that we're studying different populations, but we're coming to the same conclusions. So first thing I want to say to you, I want to apologize. The most difficult thing about my presentation is probably my Boston accent, so I hope you'll be able to interpret the things that I'm saying. I will be presenting findings that I hope are simple and easy to understand. Perhaps one of the major differences is all of the presentations up to now about people who died from overdoses. And what we're talking about is people who come into an ED, most of whom, as far as we can tell, have survived. So it's a little bit different look. The other thing is that as opposed to looking at the big picture across states and across the whole country, we look primarily at hospitals, trying to figure out what hospitals are doing, what they're learning, and how we can help them out. We also have a focus on trying to set up a system that is more rapid. As you'll notice that a lot of the material that was shown earlier is maybe a year old, and we're trying to create a system that provides a little bit more recent data. So with that, let me see if I can do this. All right. So I did want to say this one thing. I've been working in the drug field. I went to graduate school in Washington University in St. Louis and worked with Lee Robbins on her classic study of Vietnam veterans. And I remember all the way back then, we found the same thing, the polysubstance use. So it hasn't changed. Maybe there's a few new drugs, but the same thing, that it's a multiple drug exposure, at least, phenomenon. So for over 30 years, I've been involved in launching epidemiologic systems that rely on urine drug analysis to track emerging drugs. Why do you need urine analysis? Well, in the 70s, during the drug war, people didn't want to admit they were using drugs. It's certainly not that they used it in the last couple of days, and the urine analysis could pick that up. So we started off with that, but even now it's changed, because now that the drug war is over and drug use is being destigmatized, people oftentimes don't know what they were taking. You can look back at what happened on CNN in their special last night to all of these people who said they were taking pills that looked like they were Xanax or some other prescription drug, and lo and behold, it was laced with fentanyl, or it was fentanyl. So basically, I'm very careful, and I hope I don't make this mistake today, not to talk about drug use as opposed to drug exposure, because when we find a urinalysis positive for a drug, we don't know if the person intentionally used it or if it was unintentionally provided. So we started off with the DUF program, drug use forecasting, or which later became the rescue drug abuse monitoring, where we would send researchers into booking facilities to collect a voluntary urine sample. We tested them for about 9 drugs. Do you hear me? 9 drugs. That's all you needed in the 70s. And it was included the opiate test, which I'm going to talk about in a minute, that screen. So we would test them, and we could track what drugs were showing up in the arrestee populations around the country. Later, when I left being a visiting fellow at NIJ, we started a new program called Opus in the state of Maryland, where instead of sending researchers in to collect urines, we realized, boy, at that time, the probation department was collecting 100,000 urines, like in Maryland. And so if we could just collect some of those urines, we could send them to a lab and retest them. And so we did that for a while. And then we got to working with ONDCP, who gave us some funding to create the Community Drug Early Warning System, which was a system whereby we went beyond just criminal justice places. We went to places that had ongoing drug testing programs. They sent us urines, we sent it to a lab, and lo and behold, we could show them what they were missing. And then when we launched for NIDA, the NDUS, National Drug Early Warning System, between 2017 and it was about 6 years that we did this, we started having treatment programs, and anyone basically who in a health facility was collecting urines, they could send us 25 urines de-identified, and we would have them tested for many drugs and tell them what was going on. All right. So then we moved from that to the EDS project, which I'm going to talk about today, which is the Emergency Department Drug Surveillance Project. And basically it started off like this. Well, if hospitals are already doing all of this drug testing of people coming in, why can't we go and access their electronic health records and be able to plot what was going on in terms of drug trends in those hospitals? It was like a gold mine of material. So we started doing that. We tested it out in Maryland, and then we went national, again, funded by ONDCP. We went national, and we're in about 31 hospitals, I think, now around the country, and I'm going to show you that. And then we went and we started just this year the Maryland EDS project, which is the first statewide EDS program. And I'm going to present you the first results to go public from that because they're kind of amazing. So with that, as a background, I wanted to just give you this. It says why it's important to do the drug testing, the urine testing in the hospital. This is a study we did in Maryland in 2 counties in 2016 because there was an outbreak of synthetic cannabinoid use and everyone was concerned about it. So we asked the 2 hospitals to send us some urine samples, de-identified, from patients who came in and whom they thought had been exposed to synthetic cannabinoids. And when you look at this results, let's see, it's kind of amazing. We sent them to our laboratory because the hospital couldn't test for all of these drugs. And look at this. Only 20 to 23% of these patients whom they thought were involved with synthetic cannabinoids actually were. What were they involved with? In Prince George's County, you got PCP. And Prince George's County is known for having a lot of users of PCP. And then in the Baltimore hospital, we found some fentanyl, but we found a lot more cocaine. And we did find marijuana too, which I don't know if it's relevant. And I also want to show you this at the bottom. This is the number of the above drugs that each group tested positive for. Notice that a fourth to a third had 3 or more of these drugs or drug classes in their specimens. So the bottom line, it's really important for everyone to understand that you can't rely on the clinical records to know exactly what people came into the emergency department with. You don't know it. You need the toxicologic results. All right. And that's really important. And that's the strength of EDS is not only is it very rapid, but it's focused primarily on the urinalysis results from the hospital. Okay. So there's 2 types of EDS projects that we have. The National EDS project collects quarterly. That means every 3 months, hospital electronic health records, de-identified, are sent to us containing limited data sets of patient urinalysis results and a one-time, this is a little different from what I've been saying, and because we know that the hospitals around the country only test for a small number of drugs, in fact, they test for the drugs of the prior epidemic. And we could go into a long discussion about that. I'm not going to do it now. So what we do is every hospital participating in the National EDS projects sends us a sample of 150 already tested urines that we send to a collaborating laboratory that now tests them for 500 substances. So basically, we are able to come back with a report that says, these are what you found, but look at what we found. And look at all the drugs that are showing up that you're not testing for. All right. Now, the Maryland EDS that I'm going to show you later, which is statewide in Maryland, only collects electronic health records, but no urine specimens. But, and this is important, we give each hospital 50 fentanyl dipsticks with which to test consecutive hospital positive specimens. So basically what we're trying to do is we're going into hospitals and saying, okay, here's 50 fentanyl dipsticks tests. Go ahead and test specimens, and now we'll give you an idea how much fentanyl is in your population, okay? So going back to our first EDS project, the pilot study in Baltimore, we got this result from one of the Baltimore hospitals. Look at this. This is opiates. And this is, by the way, from 2016 to 2018. And by the way, as a researcher, it's so amazing to me that once we get the approvals and they will create an export for us, And in a minute, you've got 5 or 6 years of data showing you the trends in the hospital. Now look at this, opiates down. I know one of the prior presentations is also talking about opiates going down. So we said, why in the world is opiates going down in a town where we know there's been a long history, multi-generational, of heroin use, okay? And opiates generally pick up the heroin, or morphine, or codeine. So we talked with our collaborating physician, Dr. Zach Desmond, who will be speaking, I think, today at 3:30. And we couldn't have done this project without him, because he got us entree to the hospitals in Baltimore so we could prove the concept. And then he helped to lead a number of articles that I'm just going to show you in a minute. So look at this. All you find is opiates, and the highest percent positive for any drug back then was about cocaine. All right. So what Dr. Desmond did was he went and he bought some fentanyl dipstick tests, and he tested urines before he sent them to the lab, and he interviewed the people about the result, and then he compared the fentanyl dipstick results to what the hospital found. All right. These were ED patients with apparent opioid overdose, withdrawal from opioids, or requesting treatment for SUD. 83% of these people tested positive for fentanyl. 56% of those who had a standard urine drug screen and fentanyl testing tested positive for fentanyl, but negative for opiates. In other words, the hospital tests for opiates. They would have missed most of these people. And only 5%, this is really important, only 5% when he interviewed them said they knowingly took fentanyl. Okay, so look at this chart. This is the new chart. 2 hospitals that he worked with started routine testing of fentanyl. And so remember, I showed you this before up to here, and all you saw was this. Now when you got the fentanyl being tested for, oh my gosh, it's 85 to 95% of the patients are being tested positive for fentanyl now. And this, by the way, is the data that we try and update every quarter, so we can know what's happening with all of these other drugs that the hospital tests for. Okay. This result, by the way, was published in an article led by Dr. Desmond in the MMWR. And I'm not going to go over the findings, but you can go and look at this article you want, or look at the slide later. All right. So, it's rare. That's R-A-R-E with a Boston accent. It's rare to be doing social research like we do, and to make a difference to policy so quickly. It usually takes a long time for stuff to happen. Well, what happened? I already told you that in the 2 hospitals, 2 of the hospitals where Dr. Desmond had done his dipstick research, they added fentanyl to the routine screen. Following their participation in EDS phase 1, the University of Utah Hospital added fentanyl to their routine screen. And then we've been working with this brilliant colleague at the Scripps Clinic, Dr. Ronit Lev. I'm sure many of you know her, and she worked with us. And because of her results, she was able to get California to recently pass a state law that requires test fentanyl to be part of standard hospital drug testing. And I'm glad to tell you that Maryland right now is considering a bill to do the same. So basically, I probably should have told you this before. We've gone into a lot of hospitals. They don't test for fentanyl. I mean, we go through a COVID epidemic, and we say in order to determine where it's going and where it is, we have to test. Well, it is kind of amazing that across this country, very few hospitals test patients, OD patients, for fentanyl. Go and ask them. I can't explain why they did it, other than some of them, it's like inertia. They have contracts, and they can't add new drugs that they don't test for already in their contract. But testing for fentanyl is not expensive. So this shows you the National EDS project, where we are in the country. And I wanted to show you a lot of the if you see, a lot of these hospitals are in Florida. Well, that's because we've been working with HCA Healthcare, and they have helped us to get entree to their hospitals, to get the electronic health records, and to get the 150 urine specimens. This is for the National EDS, where we collect the urine samples. And I wanted to show you the results from hospitals HCA hospitals. And I have to tell you, when we get the 150 specimens sent to us for retesting, 100 are chosen because they tested positive for something in the hospital screen, anything. And then 50 are negative, they send us for all drugs in their screen. And what I wanted to show you across the country where we've done this with HCA, you find fentanyl in every hospital. But do you see this bullet? None of these hospitals routinely test patients' urine specimens for fentanyl. The other thing I want you to understand from this is fentanyl is rather rare, much rarer, R-A-R-E-R, much rarer in specimens that contain no drugs. Saying it in another way, as other people have said, when you find fentanyl, you usually find other drugs. It's just what happens. And we've been finding that around the country. And I'll just tell you, we have this saying at CSER that the drug, this time we're talking about fentanyl, but you could have talked about crack cocaine, or you could have talked about heroin. That drug is the tip of the iceberg of what a person is exposed to. It's been that for years. And what we do in this country is we focus on drugs, one drug at a time. And I think that my co-presenters and I would agree that if you want effective policy, we have to start looking at the total. They said a holistic approach. We often say the person, it's not the drug, it's the person. What is the person letting themselves be exposed to intentionally or unintentionally? Okay, now we worked with the EPIC research group, and I think all of you know who EPIC is. They run one of the largest electronic health record systems in the country. And we worked with them, and they did this analysis of over 300,000 overdose patients between 2018 and 2022. And you can see they found that only 5% of them had been tested for fentanyl. However, what they also found is if they did test for fentanyl, look at what the percent positive, it was very high. By the way, this is much higher. It turns out, I took the numbers out of the slide, but opiates, the opiate screen, which can't pick up fentanyl, is much more likely to be tested for among patients. But the percent of the opiate tested people who test positive is more like 13% as opposed to almost 42%. So we're sort of testing in the wrong place for the most part. So this is the Maryland Eds group that I wanted to show you. And this is, those of you who don't know Maryland, I just want to show you, we have hospitals both in the city near Washington, in the rural areas of Maryland, and we've got hospitals towards the Eastern Shore, which population grows tremendously in the summer. So anyway, these are the first results from this dipstick study. I've never shown them publicly before, so bear with me for a minute. Remember, what happened is specimens were selected from consecutive patients from any hospital unit that were positive for at least one drug by the hospital's testing. Why do we do that? Because we knew if we didn't have a lot of resources and time to collect to do a lot of more specimens, so we focused on specimens that already tested positive for the limited drugs in each hospital's panel. That's what they chose. They came from any unit, so it wasn't necessarily someone who came in for an overdose. They were at any unit where they sent a specimen to the lab to be tested. Patients that were administered fentanyl as part of their medical care at the hospital were excluded from the hospital. Look at what we found. These are the first results. We're going to have results from another, I think another up to about 18 total. Look at this. Every hospital that we went to found some fentanyl. Okay. Overall, collapsing across all was in 12%, but you can see it varied across the state. And this is in agreement with what the prior people were saying, prior speakers. Drug use is local. What we find in Baltimore is different than what we find in the District of Columbia, 40 miles away. So national estimates gloss over these distinctions. You have to do sort of what some of my prior speakers were doing. You have to look specifically at the location where you are, because that's where the particular drugs will be found, and it will differ from a place maybe 50 miles away. Okay, now, so we found fentanyl in every one of these hospitals. This tells you, of the specimens that were positive for fentanyl, how many also tested positive for opiates. Look at this. We couldn't create stats from this, so we summed it. Only 19% of the fentanyl positive specimens by a dipstick also tested positive for opiates. Put another way, 81% were not positive for opiates. In other words, if the hospital thinks they were picking up opioid users with their opiate screen, because they're not, they're missing it. And this is really pernicious, because if there are methadone programs, I've been told, if there are programs that test their people who want to come into methadone and they test them with opiates but not fentanyl, then there would be people who need treatment who aren't going to get in because they weren't tested for fentanyl. That's something that the country and the FDA really should look at, because you wouldn't want anyone to be prevented from getting methadone treatment because the program wasn't testing for the right drug. By the way, the clincher here is none of these hospitals routinely test for fentanyl. You know, I sometimes think if I went up to people on the street, given all they are hearing about the overdose problem, the fentanyl overdose, and the people dying from fentanyl, would they believe it if I told them most hospitals don't test for fentanyl? Now, in their defense, they say the doctors in the ED need to treat the symptoms, and they oftentimes can't wait for the result. But the point is, even if they don't have it for the treatment, once you get the results back from the fentanyl test, you can now tell that patient or other patients, look, there's a lot of fentanyl out there. It's being mixed with cocaine, or it's being mixed with other drugs. We really need to do that. So let me show you this. We took these specimens that tested positive for fentanyl by the dipstick and compared to the ones that tested negative. All right, so it's the 48 that tested positive to those who are negative by the dipstick. Look at this amazing, I didn't expect it to be this high. 63% of these patients who tested positive for fentanyl tested positive for cocaine, compared to only 24% of those negative by the dipstick. We also found, so you had cocaine, you also found stimulants, twice as likely to be found in those with the fentanyl than without the fentanyl. So there is something going on. And by the way, think about these results are current. These results were collected within the last 2-3 months. So we're not talking about something that happened 6 months ago, a year ago. This is what's going on right now. We also found 39% positive for methadone versus 8%. I do not know what that means. We're hoping someday to get some additional funding so we can start interviewing people and finding this out. I know Dr. Desmond would love to do that, our colleague, and maybe we'll be able to do something like that in the future. So fentanyl shows up with other drugs, and you need to test for fentanyl. So my conclusion is, I've sort of been touching them along the way. There is a dire need. I should have put it critical. There is a critical need for most hospitals to add fentanyl to their standard urinalysis panels so that patients may be properly treated and informed of the drugs to which they are being exposed. I apologize for saying something that seems so obvious that hospitals should be doing. I want to also add that the commissioner said, what new products do we need? And I'm not clear that this is under the FDA's jurisdiction, but there's something called clear approval for tests, which allows a doctor, a clinician, to use the results to treating people. The fentanyl dipstick is not clear approved. So we need to get some clear approved rapid dipstick tests for fentanyl so people can do what we're doing. They could test people right there in the emergency department for fentanyl and then use the results to treat them. That is a dire need. There's also, I've been sort of touching on this, and I haven't shown you the results. There's a need to establish a national epidemiologic system for collecting and analyzing hospital patients' urinalysis results in order to monitor drug epidemics. We need to not only get the results from the hospitals of the drugs they test, but we also need to have a system where hospitals can send some specimens into a lab and have them tested for 500 drugs so you can find out the new drugs that are there. That's what we're doing now. Our current collaborating drug laboratory has now added xylazine to their group of 500 drugs. So everyone who participates with us and sends us specimens will now have an ability to know whether or not xylazine is showing up in their specimens, in their patients. I'm sorry if I ran over one. I thought I had to 2:15, and it's just 2:15. And I appreciate the opportunity. I hope I didn't put too many people to sleep. I think this is exciting work that we're all talking about, and people really need to design drug policy focused on what the science is showing. Thank you so much.
Fabulous. And Dr. Wish, I was just there as your 1-minute reminder. So thank you so much for walking us through this. As we think about the arc for this session, we moved from better understanding the individuals who are exposed to drugs and experience overdose, to better understanding the products that are involved in that exposure, to then better understanding what is happening, or as you noted, not happening in hospitals where we're trying to better understand and treat. So thank you all for giving us that arc and the conclusion that this is a space that really needs that patient-oriented approach for the polysubstance dynamic and better understanding all the complexities there. Thank you so much to our session 1 presenters. With that baseline, we're going to move directly into session 2, where we're exploring the pharmacology of opioids and overdose management products. I'm going to say that as we do that, the foundation team is preparing to post the slides on our website. So if there were some of those things that you wanted to zoom in on and see more clearly, that should be available within about 10 minutes that you could look at those slides. So let me now turn to session 2, and to kick us off, I am pleased to welcome Dr. Albert Dahan, a professor of anesthesiology at Leiden University Medical Center, or LUMC. Dr. Dahan is also the chairman of the LUMC Institutional Review Board and vice chair of their Research Advice Committee. I'm going to turn it over to you to lead us through your presentation. Thank you so much.
Thank you very much. I hope you can hear me. I'm very honored to be present here today and talk about something that is close to my heart. That's opioids, opioid-induced respiratory depression, and reversal of opioid-induced respiratory depression. My name is Albert Dahan. I'm an anesthesiologist, and I will take you initially focusing on 3 questions that I have and would like to discuss with you. The first question that I have is, how difficult is it for naloxone to displace an opioid from its receptor expressed on the respiratory neuron, as I show you here? And very closely linked to that is my question, how effective is naloxone in restoring respiratory activity, especially when cardiac output is very low and the subject is not breathing anymore, the individual. And I will briefly touch on something that we're currently exploring in our laboratory, and that is how to deal with somebody that overdosed on an opioid combined with another drug that is respiratory depressant and causes severe sedation, like xylazine, an alpha-2 adrenergic agonist. How to deal with that, because naloxone is aimed at reversal of the opioid and not on non-opioids. So let's first discuss some physiology. I will discuss a little bit of physiology today and a little bit of pharmacology. Well, this is the brainstem, and these are the respiratory centers within the brainstem. On the top, there is the pons, the bottom line is the medulla, and you can see the respiratory centers and the complexity of the whole system, the many centers involved. And the green square are the opioid receptors within the respiratory center. And they're everywhere, but most important for respiratory depression, they're present in the parabrachial collicular fusee center and in the pre-Butzinger complex. And when the opioid and exogenous opioids interact with these receptors, well, respiratory depression occurs, respiration slows down. I will show you that later. And at one point, respiration stops, and the individual will eventually die when you don't do something. But additionally, on this slide, I show you that there are many other receptor systems involved. And these are so-called excitatory receptor systems that are present all over the brainstem. AMPA receptors and serotonin receptors, and they're really important. And I will focus on that in the last part of my presentation. And there's something else that I would like to show you. Here you can see that there's a small organ present in our body, the carotid body, that's present in the bifurcation of the common carotid artery. And that's the hypoxic sensor of our body. And when you become hypoxic, because of, for instance, respiratory depression, this system is needed to cause a hyperventilatory response, a hypoxic ventilatory response, to overcome that hypoxic event. And there are also many receptors available at that carotid body, and they're involved in the whole process of signal transduction. And one of them are the so-called background potassium channels. I will get back to that also at the end of my presentation, but you see that the carotid body is linked to the brainstem through the sinus nerve. It interacts with the NTS, the nucleus tractus solitarius, and from there it interacts with the motor pool to cause a hyperventilatory response. And another thing that you need to realize is that opioids affect these respiratory neurons in a dual fashion. They cause impairment of excitatory presynaptic neurotransmission, and they depress the intrinsic, well, they cause intrinsic hyperpolarization of these neurons. It's not really important, but what I want to say is that the opioids have very complex effects on multiple sites within the brainstem, indicating that you might approach one area, but then you still lack effects on other areas. And this is one of the reasons, especially for non-opioids, to produce such complex respiratory effects that are very difficult to reverse with naloxone. Well, I want to show you several phenotypes of respiratory depression. This, for instance, is a slide that shows you inhaled and exhaled carbon dioxide. On the x-axis is time, on the y-axis is the CO2. And you can see this is an actual patient that was overdosed with morphine. This is an actual tracing of the overdose occurring. And you can see that there is a period of irregular breathing, sometimes a slowing of breathing, then breathing is increased again. You can see small tidal volumes, somewhat greater tidal volumes, and you can see that this transitions into what we call cyclic breathing. The subject, the patient, has a period of breathing, he stops breathing. You could even compare this to gasping. And at one point, his breathing is totally absent, and that's what we call apnea. And this is a typical overdose sequence that you see post-operatively in an individual, in a patient that still has some anesthetics on board. Very irregular breathing. Now I'll show you another phenotype. I call this respiratory phenotype number 2 of an individual, an opioid use disorder individual that was in our laboratory, and we overdosed him with fentanyl. We can do that quite safely. Everything is under controlled conditions. Believe me, the subject survived. There were no issues here. But you can see that there is a period of regular breathing, and at T is 2 minutes, we overdosed this subject with fentanyl. You can see that ventilation suddenly becomes a little bit irregular, but within a minute, almost a little bit longer, the patient, the individual, stopped breathing altogether, and we initiated a resuscitation. We put the subject on a mask, and it took us about 20 minutes before he started breathing on its own again. He survived completely. There was no decrease in saturation. And finally, a very common phenotype that you see post-operatively in subjects that are asleep. This is this response, this regular apneic events that occur and that coincide with decreases in saturation. Saturation decreases. It causes a central arousal response. The subject wakes up again, and he starts to breathe again for a couple of seconds, maybe a minute. Then he falls asleep again, or a deeper level of sleep, because I do not believe that the subject really was awake. And you see this cycling event. This is also quite typical from obstructive sleep apnea. it's a very common form of respiratory depression that occurs quite frequently, also in individuals that are not on opioids, but this subject was on an opioid, on morphine PCA. Now, I'd like to talk a little bit on the events that occur when you overdose on fentanyl. You do not die immediately when you overdose on fentanyl. What happens is that you overdose, that initially you have a decline in ventilation. Your breathing decreases up until, and I've shown you that in phenotype number 2, there's a cessation of breathing, what we call apnea. At the same time, almost at the same time, there is the loss of consciousness, especially when the dose of fentanyl is very high. And because the subject doesn't breathe anymore, there's no uptake of oxygen and no loss of CO2 in the lung. So there's no gas exchange, pulmonary gas exchange. The subject becomes hypoxic and hypercapnic. And especially hypercapnia induces a sympathetic stimulation, causing all kinds of cardiac dysrhythmias. But hypoxia at one point takes over and induces severe slowing of heart frequency. And you get bradycardic. At one point, you get into cardiac arrest. And when you do not rescue the subject, the individual, he or she will die. And so there are a couple of important issues that you need to realize. And one of them is that timing will vary. Like I showed you before, in post-operative patient, it took 20 to 30 minutes before the subject stopped breathing. But in the second phenotype that I showed you before, the fentanyl overdose caused an almost immediate cessation of breathing. So this timing varies. It depends on the opioid dose and whether or not the subject was used to taking opioids, or maybe he was used before, but there was a drug holiday for whatever reason. Maybe he was incarcerated, he starts using his previous dose again, and then these events occur quite frequently when he takes his earlier or a way too high dose of fentanyl. And there are two questions that you need to ask when you approach a subject in a community setting. The first one is the individual still breathing? And you can do that by putting your hand in front of his mouth. You can feel his breathing, yes or no. The second one, and I find it even more important, does this individual still have a pulse? Is there still some cardiac action? And you can feel his pulse, but you need to realize that occurs quite often. Many cases of an opioid overdose in which we believe there is no cardiac action still have some cardiac action, but due to the slowing of the heart, you do not feel that. There's so much going on when you test the subject in a community setting. So be aware that you test your subject to determine what's going on, because when there is no pulse, you have to resuscitate him immediately by giving him chest compressions. Now, I spoke about physiology a little bit. Now let's go into pharmacology. And if we start with the lower graph, and if we overdose, if we give somebody an opioid, it doesn't need to overdose. The opioid comes into the system, it distributes in the system. I show it here with 3 compartments. I show it here as well. You have the central and the 2 peripheral compartments. What you need to realize is that the opioid then passes the blood-brain barrier and gets into the transitions into the brain compartment. And this passage can be very, very quick. So opioids like fentanyl and sufentanil and carfentanil very rapidly pass the blood-brain barrier because they're highly lipophilic, but they're also very slow opioids like morphine and buprenorphine that are still lipophilic, but less lipophilic, but they take more time to cross the blood-brain barrier and transition into the brain compartment. Well, the opioid is then in the brain compartment and then attaches to the receptor, the mu opioid receptor on the respiratory neurons, here given as an R, and the red square is the opioid. But then receptor kinetics can come into play. They dictate how rapid the opioid attaches to the receptor, but much more important, they also determine how rapid the opioid dissociates from the receptor. And you have certain opioids that have a very high affinity for the receptor. And it's then very difficult for naloxone to displace the opioid from the receptor. And this is defined by the rate constant K-off. The smaller K-off, the higher the affinity of the opioid for the receptor, and the more difficult it is to displace the opioid from the receptor. And I will show you some examples in my next slide. But if the receptor is activated within the respiratory network, the one that I showed you in my previous slide, ventilation will slow down and the phrenic nerve activity will slow down, and you get into a condition of respiratory depression. But very, very important is the parameter K off. And as I state here, the opioid receptor kinetics determines the efficacy of naloxone. And I give you here some examples of opioids with a very low K off that are very difficult for naloxone to displace from the receptor. And the one that has the highest affinity, the lowest K off value, is carfentanil, followed by buprenorphine and sufentanil, morphine, and fentanyl itself. So these opioids are difficult to displace. Also for morphine, I show you that here. This is an experiment that we did more than a decade ago, in which we infused morphine intravenously to a subset of volunteers. I think it's around 20 volunteers. And we were very cautious, so their ventilation decreased by around 30%. At one point, we gave 400 micrograms of naloxone intravenously. And you see that it takes around 20 minutes before you have full-blown reversal of the effect. So the effect is relatively slow. And here are some simulations in which I vary, on the right side, I vary the rate constant K off. So I do a simulation in which I administer an opioid here. In an opioid with a very low K off value, ventilation goes down, and you can see a very small and slow effect of a fixed dose of naloxone. An opioid that has a higher value of K off shows you much more rapid and greater effect of a fixed dose of naloxone. You can say, well, what we will do is then we give a higher dose of naloxone. Well, indeed, that's what you should do. But still, even with a high dose of naloxone, I show that on the left side, the rate at which respiration is reversed doesn't decrease. The effect will be greater, but it also occurs very, very late. And to show you that, I'll show you, there's one additional thing that you need to realize is that some drugs, especially fentanyl, accumulate in the body. So if you overdose on fentanyl, the fentanyl stays within the body for a very long period of time. And that's quite dangerous because naloxone has a very short elimination half-life. So you can possibly reverse initially the fentanyl effect, but due to the short action of naloxone, respiratory depression will recur again. And I show that here, and this is what we call the context-sensitive half-life, infusion duration of fentanyl. So the more fentanyl you give, the larger the time it takes before there is a drop of 50% in plasma concentration of fentanyl. In contrast, for sufentanil, although it's also very lipophilic, it declines much more rapid. And so fentanyl is especially prone to respiratory depression because of two things. I show you that here, because of slow receptor kinetics and because it accumulates in the system. So the solution is check whether or not the subject has pulse and breathe. If he does not, start chest compressions and artificial ventilation, and give a high dose of naloxone. In a community setting, I would suggest to give it intramuscularly or intranasally. And in the next presentation, David Strauss, with whom we did several studies together, we will discuss dosages. I will come back to it a little bit, not much. And when you have a patient in the hospital that has overdosed, I would give it intravenously, the naloxone, and start a continuous naloxone infusion. Now, I give you some examples of studies that we did together with the FDA. Here is an opioid use disorder individual that was treated with a high dose of sufentanil, and we gave a very high dose for a prolonged period of time. And on the y-axis, you see the CO2 as a marker of respiratory depression. You can see that CO2 increases, so ventilation dropped significantly. At one point, we gave 4 milligrams of intranasal naloxone, and you see a decline in CO2, indicative that respiratory depression decreases, but the peak effect, again, occurred at 30 minutes. However, and this is really important, you need to realize that for effective gas exchange, you do not need a complete reversal of the opioid effect. What you need is a reversal of about 40 to 50% of ventilation. And that occurs much, much more rapid after about 5 to 10 minutes. So while peak effect is after 30 minutes, there's already adequate ventilation after about 5 to 10 minutes. But I show you here also that after naloxone, even the 4 milligrams worked effectively for 30 minutes, the effect weaned, became less, and respiratory depression came back. This is what we call re-narcotization. So be very careful, or treat the patient, the individual. Again, that I show you here. This is again an opioid use disorder individual that we treated now with fentanyl, high dose fentanyl. We gave fentanyl for almost 300 minutes. You can see the increase in CO2, the administration of intranasal naloxone, 4 milligrams, the decrease in CO2, peak effect after 40 minutes, again, related to the very low K-off value, but 40% reduction after about 12 minutes, indicating that this is adequate. Within 12 minutes, the gas exchange, again, is adequate to cause survival of the individual. While we see re-narcotization occurring, and we retreated the subject. At one point, we saw re-narcotization again happening, and we gave him intravenous naloxone. Now, again, a short summary. Fentanyl overdose is difficult because of slow receptor kinetics and accumulation. This I showed you, like I said, regarding naloxone dose. Wait for the talk by David Strauss. But what I would like to stress is that in our opioid use disorder individuals, with the treatment of 4 and 8 milligrams intranasal naloxone, we saw extreme withdrawal and excited delirium that we had to treat with an alpha-2 agonist, clonidine. This was really, really serious, and you need to realize that the subject might become extremely aggressive when you treat him with these doses of naloxone. Although, you save their lives, they still become very, very aggressive. Now, very shortly, I would like to address the issue of the combination of an opioid and a non-opioid respiratory depressant drug like xylazine, but it could be any other drug, could even be alcohol, high-dose alcohol. Xylazine interacts with an alpha-2 receptor, causes severe sedation and respiratory depression. How do you treat such a subject? Well, naloxone alone will not work. You need to realize that. If the subject is without pulse and without ventilation, start artificial ventilation and chest compressions, give intranasal naloxone to take away the opioid component, but then if the respiratory depression is still present, well, you need to realize that there are other possibilities. And one of the other possibilities is to give an agnostic respiratory stimulant. So that's a respiratory stimulant based on these excitatory receptor systems that I showed you in my physiology slide in the beginning. And still there are none currently well tested, sufficiently tested, I have to say. I'm working on several of those agents. One of them is ANA001, and I recently also tested doxapram. Both of them act on the carotid body. They act on these potassium channels that I showed you. And there's also an ampakine CX717 that acts on the AMPA receptor in the brainstem. But I would like to end with one slide that is on doxapram. So we tested the effect of doxapram. What do I like about doxapram very much? I really think that it's a possible drug to combine with naloxone. Why is that? Well, that I show you here on my last slide on C, the cardiac output. Doxapram is an analeptic drug. It not only reduces respiratory depression because of its effect on this potassium channel, but because of its analeptic effect, it also increases cardiac output. And as you understood from my talk, sustainment of cardiac output is really, really important, because without any cardiac output, you can give as much naloxone as you wish, but it will not get to the brainstem. You need cardiac activity. With that, I would like to end my presentation and give the floor back to Susan. Thank you very much.
You hearkened me back to my pharmacology days in pharmacy school, but it's so helpful and illustrative. Thank you for that presentation, and we'll welcome you back to the panel presentation right after we hear from our second presenter. So our second speaker today is Dr. David Strauss, I should say our second speaker in this session, who is Director of the Division of Applied Regulatory Science in the Center for Drug Evaluation and Research at FDA. Dr. Strauss, I'm going to step out of the way so that we can jump right into your content.
All right. Thank you, Susan. Thank you, Albert, for the initial presentation in this session. It's a pleasure to be here today. I'm going to discuss assessment of intranasal naloxone repeat dosing strategies. And I'm working on advancing. There we go. So, as background, community use intranasal naloxone products are sold in packages with 2 single-use nasal sprays, and they're approved for administration as a single dose with repeat doses every 2 to 3 minutes if the patient does not respond. Fentanyls, and I'm referring to fentanyl and other fentanyl derivatives, can cause rapid respiratory depression and death and may require higher naloxone doses. And questions have emerged as to whether current naloxone dosing is adequate in the era of illicitly manufactured fentanyl. This has included questions such as should more than 2 doses be included in packaging, and or are higher doses of naloxone needed? Or what is the appropriate timing of giving repeat dosing? So we conducted a randomized clinical trial, a crossover trial in 21 healthy participants to compare naloxone plasma concentration between different intranasal naloxone repeat dosing strategies. And this graphic here shows the 3 dosing strategies that we compared. The first one, 2 doses standard, as I'll refer to it, and it's 1 dose at 0 minutes and a second dose 2.5 minutes later. The second one is 4 doses standard. This is 1 dose at 0, 2.5, 5, and 7.5 minutes, and 4 doses rapid, which is 2 doses at 0 minutes and 2 doses at 2.5 minutes. The primary outcome of this study was the first time point when there was higher naloxone plasma concentration in the 4-dose groups compared to the 2-dose group. In addition, we pre-specified to use the data to predict the impact of each dosing strategy on brain hypoxia time and cardiac arrest following fentanyl or carfentanil overdoses with a previously developed and validated pharmacokinetic pharmacodynamic model. This graph shows the results from the study of the naloxone plasma concentration on the y-axis over the first 15 minutes on the x-axis. The 4 doses rapid group is in green, and below the graph, the timing of the naloxone doses is shown. The 4 doses standard is in red, and the 2 doses standard is in blue. On the following slide, I'll show the comparison between these different dosing groups. I'll note this is a log scale on the y-axis. So this slide shows a comparison between the naloxone dosing strategies. The y-axis is the geometric mean ratio. So the green line shows the ratio of the concentration at each time point of the 4 doses rapid group compared to the 2 doses standard group. And the red line shows the comparison of the 4 doses standard compared to 2 doses standard. The dotted line is 1, and when the value is above the dotted line, that means there is a higher concentration. The first time point with higher plasma concentration in the 4 doses rapid group compared to the 2 doses standard was at 4.5 minutes. And the first time point with higher plasma concentration in the 4 doses standard group was at 10 minutes. So what does this mean? Well, we took this data, as I mentioned, and we used this new data in this developed and validated pharmacodynamic model that we published last year, and a schematic of the model is shown on the right. I'm not going to go into the details here, but it has the pharmacokinetics of each drug, opioid receptor binding model where you can bind fentanyl or another opioid or naloxone, and then the pharmacodynamic model of the effect on ventilation and the feedback of many other physiological mechanisms going on in the body. And we're going to see some of the results of that. So for the overdose simulations, we selected 2 fentanyl doses that were based on simulating the intravenous doses that would result in the mean and 1 standard deviation above the mean plasma concentration from a prior study of approximately 500 unintentional fentanyl overdoses with postmortem data. These following slides are going to show simulations of an average or typical patient from the higher of the 2 doses, 1 standard deviation above the mean. And on this graph, we're showing the percent of the opioid receptors bound by fentanyl after administering fentanyl intravenously when there's no naloxone administered. In blue here now is what happens when you administer 2 doses of naloxone, according to the quote standard nomenclature. The first dose of naloxone is administered 1 minute after ventilation decreases below 40% of baseline, and the second dose is administered 2.5 minutes after that. As naloxone displaces fentanyl from the opioid receptor, the blue line comes down. Now, this shows 4 doses standard. You'll notice, you may have seen, I don't know how it looks in the webinar, but a red line flew in. It is basically overlapping with the blue line, so you can't see it. There was essentially no difference between the 2 doses standard and 4 doses standard in the first 10 minutes here. And here is the 4 doses rapid group. There is a more displacement of fentanyl from the opioid receptor. This slide shows the effects of ventilation in the same simulation. The dotted line going across is 40% of baseline ventilation. With administering naloxone, the 2 doses standard here in blue, ventilation recovers. And I'll point out in the black no naloxone line at the bottom, there's an X. That is the time when the simulated patient no longer had any cardiac output and cardiac arrest was considered to have occurred. With 4 doses standard, once again, it is essentially not different from the 2 doses standard, but the 4 doses rapid group does result in ventilation recovering faster. This slide shows cardiac output. After administering fentanyl, there's an initial increase in cardiac output that is compensatory, and there's an even further increase in blood flow to the brain. But after about 6 minutes, there's decompensation progressing to decreasing cardiac output and cardiac arrest. With naloxone, cardiac arrest does not occur. Cardiac output returns to normal. With 4 doses standard, it is about the same as 2 doses, and the 4 doses rapid, it returns back to a normal cardiac output level sooner. And finally, brain tissue oxygen. This shows a fentanyl overdose. There's a brief increase of again, there's a compensatory increase in blood flow initially, and but then without administering naloxone, the patient goes on to die. But with 2 doses of naloxone, brain hypoxia goes away. It's the same with 4 doses standard, and with 4 doses rapid, there's a recovery a little bit faster. We then simulated 2,000 different patients with different pharmacokinetic and binding parameters to capture variability. And also, in addition to the naloxone dosing strategies from the clinical trial we conducted, 2 additional doses were included. This was administering a single dose of intranasal naloxone, 4 milligrams, 1 dose at 0 minutes, and also 2 doses at 0 minutes, which we refer to here as 2 doses rapid. And so those additional dosing schemes are shown in black in this table and will be on the following slides. This slide now shows of the 2,000 simulated patients, the percent of simulated patients experiencing cardiac arrest after a fentanyl overdose. The percent of patients experiencing cardiac arrest goes from 0 to 100 on the x-axis. With the fentanyl dose of 1.63 milligrams, about 53% of patients experienced cardiac arrest, whereas with fentanyl 2.97 milligrams, about 78% experienced cardiac arrest. There's a reduction in the percentage of patients experiencing cardiac arrest with 1 dose of naloxone. And then I'm going to just have this sequential rows appear, and then I'll talk about them. This is the result with 2 doses standard, 4 doses standard, 2 doses rapid, and 4 doses rapid. What you may notice is that there is a reduction in the percent of patients experiencing cardiac arrest with 1 dose of naloxone, also with the 2 doses standard and the 4 doses standard, but there is not much difference between these points that are within each of the boxes. There then is a further decrease in the percent of patients experiencing cardiac arrest with the 2 doses rapid and 4 doses rapid, but there is not much difference between the 2 doses rapid and 4 doses rapid. And I'll come back to this, but the sequential doses every 2.5 minutes in these simulations were not preventing many additional patients from developing cardiac arrest. These are similar simulations, but with carfentanil. This is 1 dose of naloxone, 2 doses standard, 4 doses standard, 2 doses rapid, and 4 doses rapid. Once again, there's a similar pattern of reducing the percentage of patients experiencing cardiac arrest with naloxone, and a further reduction with administration of 2 doses rapid or 4 doses rapid, but the sequential doses every 2.5 minutes, whether you start with 1 dose or you start with 2 doses, that did not further reduce the number of patients experiencing cardiac arrest in these simulations. So how does this compare to intravenous dosing? This is a schematic from a New England Journal Review article on management of opioid analgesic overdose. And this is referring to emergency department application or with advanced life support providers, important to support respiration, and then start with a low dose of potentially 0.04 milligrams IV, could be higher, and then to increase every 2 to 3 minutes the amount of naloxone, initially in log-fold increases. And what does this look like in terms of the plasma concentration with intravenous naloxone? This graph on the right shows the plasma concentration on the y-axis, time on the x-axis, starting at the bottom in green with 0.04 milligrams naloxone, then 0.51 and 2. How does this compare to 4 milligrams of intranasal naloxone? That is now shown with the blue curve at the bottom with intranasal naloxone, also with intramuscular naloxone. It does not immediately get into the bloodstream, and it takes It takes longer to achieve similar exposures, plasma concentrations. And so we're now going to look at how the intravenous dosing affects cardiac arrest percentage in the simulations. So this shows, again, the results of the 2 fentanyl doses with no naloxone, with a single 0.04 milligram dose of IV naloxone. This is the result. If then after the first dose of 0.04 milligrams, then 2.5 minutes later, you administer 0.5 milligrams of IV naloxone. This is the result. There's a further decrease in the percent of patients experiencing cardiac arrest. And if 2.5 minutes after that, you administer 2 milligrams of intravenous naloxone, the result is now shown in the bottom row. Here, the second dose, the 0.5 milligrams of naloxone, did further decrease the percent of patients experiencing cardiac arrest. And with IV naloxone, you're immediately achieving a near maximum plasma concentration of naloxone. And so there's still time to achieve sufficient naloxone concentrations to displace fentanyl from the opioid receptor and save additional patients. But by the third dose here, which would occur at 5 minutes after the first one, that did not rescue additional patients, although there was pretty good efficacy with just the second dose. And as a screenshot that shows both the no naloxone, then the second box is the intranasal naloxone 4 milligrams that I already went through a few slides ago. And then the bottom box is the IV naloxone that I went through on the previous slide. And this combines it all together. I'll give you just 5 seconds or so to look at this slide. I believe everyone now has the slides, but I'm not going to talk about all the nuances. So in summary, community use intranasal naloxone products in the packaging contain 2 doses. They're approved for administration as a single dose with repeat doses every 2 to 3 minutes if needed. Questions have emerged as to whether current naloxone dosing is adequate in the era of illicitly manufactured fentanyls. And in the study that we conducted in the clinical trial portion where we were measuring naloxone plasma concentration compared to 2 doses standard, the 4 doses standard first increased naloxone concentration significantly at 10 minutes after the first dose, whereas the 4 doses rapid first increased naloxone concentration at 4.5 minutes sooner, which is what you would expect. But what did this then mean? In the simulations of fentanyl and carfentanil overdoses, 4 doses standard compared to 2 doses standard did not rescue additional patients because sufficiently high naloxone concentrations were not reached prior to cardiorespiratory decompensation, leading to cardiac arrest, whereas 4 doses rapid did rescue additional patients. And the additional simulations we performed suggested that the 2 doses rapid had a similar effect as the 4 doses rapid, and repeat dosing every 2.5 minutes did not further decrease cardiac arrest. As my final slide, in healthcare settings with adequate ventilatory support, naloxone can be titrated to reverse an opioid overdose and minimize the risk for precipitating acute withdrawal in opioid-tolerant individuals. However, in the community setting without ventilatory support, there is a limited window before hypoxic injury is irreversible and cardiac arrest occurs. This can occur extremely rapidly with fentanyl and its derivatives, and leads to the question of what is the ideal naloxone dosing strategy in the community setting. Thank you very much. I'd like to acknowledge people that have contributed to this work and look forward to the discussion. Thank you.
Absolutely. Thank you, Dr. Strauss. And I'm going to ask one quick question while our panelists come on camera, and that's, could you remind us of the concentration of the naloxone solution administered intranasally?
Yeah, the commercially available formulation is that was used here. It's the 4 milligrams per 0.1 milliliters, and that is very important. And the results that you observe here, they will differ based on whether you use a more or less concentrated solution, and even beyond that, different naloxone solutions, if there can be other things in the solution that enhance absorption, and so that's something important to consider.
Right. So the dynamics there of the strength and then the other components that are present. So thank you for that. I see everybody's on camera now, so let me introduce our two new faces. So joining us for this first reactor panel, we have Dr. Bruce Goldberger, who's professor and chief of Division of Forensic Medicine in the Department of Pathology, Immunology, and Laboratory Medicine in the College of Medicine at the University of Florida, and Dr. Sander Vinks, who's been a researcher for more than 37 years and part of Cincinnati Children's Hospital Medical Center. So I'm going to first turn to our newest voices, and Dr. Goldberger, I'm going to turn to you first. What reaction do you have to what we just heard Dr. Strauss and DeHaan present?
Well, this is really very interesting information. I'm not a clinician, so I'm not in the hospital or the emergency department, but certainly as illustrated today, the evolution of newly illicit manufactured drugs have resulted in tens of thousands of deaths. And certainly naloxone is saving many thousands of people as well. As illustrated again, the challenge today is polysubstance use and the mixed pharmacologic and the physiologic response that ensues that was just described. Further, it's so common for users to ingest cocaine and or methamphetamine with illicitly manufactured fentanyl and or the fentanyl analogs. And the doses of fentanyl ingested by people today are often so high beyond amounts that were previously thought to be lethal. Blood concentrations and decedents that I evaluate daily frequently exceed 10 to 25 times what is therapeutic in someone living. So clearly the dose of Narcan needed to save individuals is absolutely related to the dose that's ingested and the resultant body burden of fentanyl, the lipophilic nature of fentanyl and the storage of fentanyl in our tissues. And then it mentioned also today are these contaminants that are found in fentanyl. And today we have an issue with xylazine that is problematic pharmacologically in regards to the obvious drug-drug interaction and the potential CNS depression. But let's not forget the possible association of xylazine with necrotic skin lesions. So I do have one question for Dr. DeHaan, and it's something that I just simply don't have an answer for when people ask me. So in individuals that are consuming fentanyl with a stimulant, obviously the interaction of the two don't cross out the pharmacologic or toxicologic effect. So, but we realize this is really common phenomenon among polysubstance users. So is it possible that the naloxone-induced excited delirium in some individuals, is that related maybe to the co-ingestion of a stimulant? So when the effect of the opioid is released, and obviously the feeling that the individual is experiencing is very distressing and dysphoric. But we also have possibly cocaine and methamphetamine in these individuals in blood concentrations that may be toxic or potentially lethal. So I would love to hear more about your opinion of the mixed drug-drug interaction between the fentanyl and the stimulants. So thank you for letting me present.
Well, thank you for a great question. Well, indeed, there are two things going on. When you combine the opioid with the stimulant, and the dose of the opioid was so high that, for instance, you lose consciousness, you're in a state of central depression, so the CNS is severely depressed. But the stimulant is also there. And when you treat with a high dose of naloxone, two things happen. You get immediate withdrawal from the opioid effect, but you get also the effect of the stimulant. And we also see that in our group of subjects. We don't administer the stimulant, but we see the withdrawal. And the response is immediate. And what we also see, we see often, and I haven't spoken on that, muscle rigidity with the opioid. And that can be extremely severe and also a cause for respiratory depression. And we have now several subjects in which the rigidity went away following naloxone and some that it did not. But it's the combination, in fact, of three things: the rigidity, the withdrawal response, and the excitation from cocaine, amphetamine, or anything else that's on board. I do have to say, I did hear somebody talk about cannabis and the combination of cannabinoids and fentanyl. We recently did a study in which we combined cannabis with, we used high-dose cannabis with an opioid, and we saw some respiratory stimulation of that combination, because due to activation of the CB2 receptor, there is some respiratory stimulation possible. So if anything, I'm not afraid of the cannabinoids. I'm afraid of the amphetamines, and especially the xylazine. Xylazine really, if you combine that, the probability, the likelihood of death is almost 100%.
So great, great reaction, Dr. Goldberger, and great question. I want to turn to Dr. Vinks quickly for his reaction, and then we're going to continue this conversation. So I promise we'll come back there. Dr. Vinks?
Oh, thank you, Susan. It's such a great pleasure to be part of this outstanding webinar or workshop. Thank you very much for including me. I just wanted to compliment our two presenters by the way they brought together physiology, pharmacology, and real-life science. I mean, this is truly a poster child of what the FDA has intended with their model-informed drug development program, because this is what we're doing here. We're bringing very sophisticated study results in a modeling and simulation platform that would then allow us to interrogate scenarios that have not been studied or are very hard to study, and come up with insights that might not be intuitive. For instance, the fact that increasing the dose not always gives you better outcomes is one of these important findings, I think, that Dr. Strauss very eloquently showed, and also was basically alluded to in the presentation of Dr. DeHaan. So I think this is truly very exciting, but also very informative. Questions that I would have, starting with, if I look at naloxone intravenous versus inhalation, is there anything that we can do formulation-wise to improve, say, the inhalation or basically the delivery to the brain? Because we're using plasma concentrations as a surrogate for something that we want to achieve in the brain or the brain stem. And I don't know, there is something as the olfactory mucosa where sometimes drug uptake takes place, where you have then drugs grow from the nasal cavity directly into the brain. And I don't know if there are any data on actual brain concentration after a fentanyl administration, either intranasally or anything else, whether there's anything that could be improved there, or whether the dose of 8 milligram is truly the ceiling and that there is no advantage of even considering higher starting or reversal doses. That's just my first line of thinking and questions that I wanted to share with the panel.
So are we open
Yeah,
for
go ahead.
discussion now?
Absolutely.
Yeah, thank you, Sander, for the comments. And I think that, and when just as a point of clarification, when you're saying inhalation, you're referring to intranasal.
Sorry, yes.
Yeah. Yeah, I think, what our study results, the simulations really highlighted was, and what I think is missed in some of the studies out there in the literature, that just do a general comparison of the total dose of naloxone administered, or what is the maximum concentration achieved with a intranasal or intramuscular compared to, let's say, an intravenous dose. But that doesn't really answer the question of how high the concentration is in the first few minutes after you administer naloxone, which is what you need to achieve if you have a patient that is apneic, approaching, having decreasing cardiac output. And so what our simulation showed was, what really mattered was the amount of naloxone you gave with the first dose, because it had to have time to absorb and get to the brainstem. And your points about could other things be done to increase the absorption in terms of the formulation, and this was sort of a, maybe alluded to in the question Susan first brought up at the beginning, what's the concentration of the solution? That is, that can all have an effect. I mean, if you take just sort of standard generic intravenous naloxone, and there are these atomizer devices, you can aerosolize it and give it intranasally. And if you give 4 milligrams that way, and it's a more dilute solution, it's not going to necessarily, or it's not going to achieve the same concentrations in the blood. And so all these factors matter, and there can be things that are done to the formulation to potentially increase the absorption.
Thank you.
So let me, go. Actually, I'm going to ask a question of all of you, so I'll let you kind of pop up a hand if you want to jump in on it, and then we'll absolutely continue the conversation. So if we think, though, about the currently available products, and we reflect on your presentations, how might that information inform intranasal naloxone dosing recommendations in the community setting? So assuming that that's what you're using in the community setting, where do you think that translates in recommendations?
Well, it would be good to hear from some of our other panelists first, I think.
Yeah, because you gave us a preview, right?
Yeah, so I don't know. Yeah, Dr. Dahan, you have thoughts on this?
Well, the problem that I have with the simulations, they're great simulation, very relevant. In real life, it takes some time before the patient is found.
Right.
And, you can hope to administer the intranasal naloxone within 1 or 2 minutes, but probably it'll be 5 or 10 minutes. And that's something that, and I know you're working on that, David, but that's something that we need to realize, because I am absolutely convinced that giving naloxone, that's my graph, it went down quite rapidly. That's the likelihood of rescue. You need to give as much naloxone as possible, as soon as possible, in the highest concentration possible, because only then you get sufficient naloxone into the brain. And that's what you want. But in real life, it might take 5 to 10 minutes. And then the high dose, I like the 8 milligrams intranasal at that time point. Hopefully that will rescue the subject. Well, that's my opinion.
Yeah, I'd like to say something. I don't have any recommendations, but there's been reports in the media about subjects that are Narcan resistant and that are simply not responding to Narcan. And using Dr. DeHaan's model, certainly there's kind of a point of no return. And I'm not clear about these reports and where are they on Dr. DeHaan's curve. But is there something we can do better to address this issue? I think also the Narcan resistant subjects may also be ingesting xylazine. And so xylazine may be on board, causing that subsequent central nervous system depression. But I see a lot of this often.
Mm-hmm.
Well,
yep, go ahead.
I'm hopefully that in the future we will combine naloxone with other stimulants that are focused on enhancing respiratory drive by bypassing the opioid effect. Because if you have a respiratory stimulant that is as effective as naloxone but doesn't interact with the opioid receptor, I think that the probability of survival increases.
Yep.
But I do not know such a drug currently that is available.
Well, and we heard earlier about the changing supply, right? And so keeping pace with the combination there, necessary but challenging. Sander, go ahead.
No, that was my question too, like to hear from Dr. DeHaan about the combination and how he envisions that this, because he mentioned three drugs that are drug development programs that are in the pipeline, I think, or two, and Doxapram, whether and how we would envision this to be rolled out, say, for community use. I mean, not every drug is available in a formulation or in a presentation that can be easily used by lay people. So I just wanted to hear what his thoughts, because he probably has a lot of experience or interaction with drug developers that are developing these other stimulants for ventilatory stimulants. I mean.
Yeah, you're correct, Sander. We're working with various companies, and the number of stimulants is quite large, ranging from hormones to potassium channel blockers to ampakines, et cetera, et cetera. The issue is that none of these drugs have been tested sufficiently. The formulations are still not there. So there's lots of work still to do. But I envision a combination of naloxone, for instance, in a nasal spray that combines relatively low dose naloxone with respiratory stimulant that can possibly both restore respiration and enhance cardiac output. But that's really key to the problem, cardiac output. And that's what I like in David's presentation. It's all focused on cardiac output, and we should step over the respiratory depression and start only examining cardiac output. How does the drug affect cardiac output? We need a drug that enhances cardiac output. Doxapram is such a drug. We already have it. It's not very potent, also causes various side effects. So we have to keep looking for such a drug. And I think everybody's working on the same problem. Eventually we'll get there. But I do not have the solution currently.
Any thoughts on new naloxone derivatives that have a higher affinity so they truly can wipe off the other opioids from the receptor? Is there any development there?
Well, David will know that.
And
Well,
yet difficult to share. David,
yeah.
Go ahead.
Well, there's the drug nalmefene, which used to be on the market in the U.S. and is an injection form, and there's been reported there's interest in developing nasal spray for that. It has some different characteristics than naloxone. That is one other sort of old drug, but Yeah, these are all very interesting questions. I think, and I've had some good discussion about potential future use of combining stimulants with naloxone or increasing cardiac output, but a lot of that is probably a little ways down the road. And if we come back to what is available now with naloxone and use in the community setting, I guess Dr. Dahan, you talked about this balance of, you can experience, I'd be interested in your perspective, you can experience severe withdrawal effects, an individual that's a opioid tolerant individual, but at the same time, administering a high dose initially, and with intranasal naloxone, unlike with intravenous naloxone, you may not have time to say, hey, let's give a dose, let's wait a little while, let's give another one. You sort of have one chance in some individuals to save them. Going on your point that, so in our simulations that I presented, we were administering naloxone 1 minute after the ventilation went below 40% of baseline. We have done other simulations where you delay it further, and you then have a lower efficacy. But taking into account some real life considerations, are there further thoughts on that? That trade-off?
Yeah, you have to start as soon as possible. I personally don't care about the withdrawal symptoms that occur. I want to save a life. For me, saving a life, that's most important. If I can save a life by giving naloxone, within a minute or within 2 minutes at a very high dose, despite the fact that the individual will become very, very aggressive, at one point you can treat that. So that is my opinion. Treat as soon as possible with the highest dose possible and the highest concentration. And I do agree with you that in real life, it will be delayed somewhat, but you need to start somewhere and you need to understand the model. And the model works quite well. And that's what I like. We don't need to do the experiments anymore. We have the data now in the model. That's what I like very much about it. You can play with it now forever.
So I want to do one piece. We're going to do just a couple more minutes. If I could do a rapid fire response to this last question. So we've talked about the models and some of the component, but what other input do we need from patients and first responders and others to further contextualize that pharmacology data? So what else would you want to hear and understand as we think about new formulations and new delivery systems and new clinical recommendations?
So it's about learn, confirm, and apply, but we're now in the apply side of things in model-informed, say, drug delivery of dosing. But what I would like to see is get real-world data back to challenge whatever it is that is presented here today, and then verify and improve or adjust where necessary. I think that makes the thing full circle and would truly help everybody, especially the community, because again, I think that's what is the most important deliverable for me, given that we do have effective drug or counteracting drugs and formulations. And now it is, how can we further optimize that and get feedback with real world data?
Yeah. So we know how they should work. How are they working? And
right.
Dr. Goldberger, this ties a little bit to something you raised at the beginning on what, if those are, I think you referred to the naloxone resistant and what that might be there. Are there thoughts of what information you would want to see to further contextualize the space?
I think we need to be better at responding to these outbreaks of new drug, because invariably there's going to be new drug. Right now we're in this pattern of fentanyl, even more fentanyl, but one day we're going to have something else. And I don't think we respond quick enough sometimes. In my area and in the clinical area, to these outbreaks. We're getting better, right? Because we're more reactive with regards to xylazine. But we need to be better in regards to the evolving drug scene out there.
Yeah, which could be helpful if it's the real world data of the performance of the intervention. It might help us, well, certainly signals improvements on the surveillance, which we need to be pursuing as well.
And being more collaborative, like we are today, bringing in people from all sorts of areas and talk about this problem. So thanks.
Well, Dr. Goldberger, you just gave us the final note to this session. So the idea of collaborative and sharing and pieces that we need to pursue. Thank you each for joining us today. We're going to go to a quick 5-minute break and then return with our final session of the day. But so appreciate you investing your time and your insight and your thoughtful approach here. Thank you so much. And to everyone in the workshop, we'll return in 5 minutes.
Thank you.
back, everyone, and I hope you took the opportunity to refresh and charge just a little bit before we settle into our final session of the day. We're going to hear again from a few speakers and then have a robust panel discussion as we did in the last session. And so I'm first going to invite Dr. Erin Winstonley onto the screen to kick off session 3. Dr. Winstonley is an associate professor in the Department of Neuroscience and Behavioral Medicine and Psychiatry at the West Virginia University School of Medicine. I feel like I should say go Mountaineers, but Dr. Winstonley, please take it away.
Thank you so much. I'm going to thank you for the opportunity to share work that we're conducting here in West Virginia. And I also want to thank the FDA and the Reagan-Udall Foundation for organizing this important event. This picture is the main overlook at Grandview. It's part of the New River Gorge National Park in West Virginia. I am not able to advance my slides. I'm not able to advance my slides.
All right, we'll go to the next slide. There you go.
Thank you. So West Virginia has had the highest rate of overdose death rate in the United States for over 20 years. And we've actually, 2017 data shows that we've had the highest rate of overdose deaths also involving psychostimulants. Opiate overdose deaths cause respiratory depression, as we saw in the previous session, and there's a significant risk of cerebral hypoxia if inadequate respiration persists for a few minutes. So our team has been investigating, and we conducted a systematic review of overdose-related brain injuries or cognitive impairments following overdose. And while the incidence of such injuries is unknown, research did reveal that these types of injuries have been reported as early as 1973 and across 21 different countries. Also, Dr. Jed Barash has actually documented a case series of amnesia, sudden onset of amnesia following fentanyl overdoses as well. So we know that this is a problem. Next slide. So reversing opiate overdose reduced in respiratory depression is really critical to not just saving lives and preventing mortality, but also morbidity. So there's a lot of limited empirical data that directly compares different modes of naloxone administration. In the previous session in Dr. Strauss's work, you've seen part of this information. So I'm presenting here just a summary of data that was published out of studies conducted in Australia, where they actually did a comparison of intramuscular formulations of naloxone to nasal naloxone. And what you can see in the slide and what they found in these two studies that they conducted was that intramuscular naloxone had higher time to adequate respiration, and people were less likely to have a second dose. And part of the reason that this may be is that nasal naloxone has lower bioavailability compared to intramuscular. So we became increasingly concerned in West Virginia and other places that I've been doing work about anecdotal reports from community members and our study participants about the need for multiple doses of nasal naloxone when reversing overdoses, and also starting to see significant morbidity among people who had actually experienced a non-fatal overdose. And that was really the background for why we conducted this study that I'll be presenting to you today. So the aim of this study was we conducted a retrospective cohort study of adult patients to try to understand the morbidity that results from fentanyl overdoses. So I'm going to be presenting to you today some preliminary data, which is about the first 83 cases that we have data on. And so this is part of an ongoing study. So in this case, cases were identified by an electronic search of medical records that had a diagnosis of a fentanyl overdose or by referral from clinicians. They presented to one of the 11 WVU medicine facilities. These are emergency departments or hospitals located across the state for a fentanyl overdose, but from November 2020 to October 2022. And cases were included in our study if there was toxicology performed at the time of the overdose that was positive for fentanyl, or if the overdose was suspected to involve fentanyl based on report from either their clinician, EMS, family members, or other bystanders that might have been at the scene, or of course, self-report of the patient. We extracted the data from the electronic medical record, and this is the preliminary data that I'm presenting. So the majority of the cases were in Morgantown and West Virginia facilities, to give you an idea geographically. And we had about 84% had a positive toxicology for fentanyl. Little over half of the cases were male, and the mean age was 38 years old. 50% had a current diagnosis of a substance use disorder, and 34% did not have a history that we could identify in their electronic medical record of being diagnosed with a substance use disorder. We thought about a quarter of the cases appeared to have been engaged in addiction treatment at the time of the overdose, and about half had a comorbid mental health problem. So the data that I'm presenting here is the results of the first toxicology that was performed upon presentation to the emergency department. And you can see here that the about 85% of those drug toxicology results involved more than one substance. And this is, consistent with data that's already been presented earlier today. So the most common drugs that were found in the toxicology results was fentanyl, amphetamines, and cannabinoids. And that's really consistent. I want to emphasize, though, that keeping in mind, because of this data source being electronic medical records, that is possible that cases were administered medications in the pre-hospital or hospital setting prior to the collection of the toxicological sample, and hence the medications may be represented in this data. And also, as Dr. Wish mentioned earlier today, clinical settings such as these emergency departments test for a limited number of substances, so it's unlikely to detect some of the more novel drugs or substances that are not showing up on standard clinical panels. Oops, let me go back. So among the cases that we had data available on naloxone that was administered in the pre-hospital setting, we saw that the dosage ranged from 0.2 milligrams to 16, and they used a variety of different formulations, including intranasal, intramuscular, and intravenous. We also had data on 27 of the cases were administered naloxone in the emergency department. Notably, we saw here that we had 6 cases that did require an infusion of naloxone, and we had 14 cases that were administered naloxone more than one time. Unfortunately, we had hoped that we would be able to understand whether higher doses of naloxone or repeated dosing of naloxone in this data set was due to longer periods of time down or unconsciousness in the individual. But unfortunately, very few of the records actually had documentation of how long the person was unconscious or down prior to the arrival of EMS or first responders on the scene. In the 41 cases where we had 41 cases that actually received more than 2 milligrams of naloxone. However, we don't know how much time elapses between the dosing. So that's something we can investigate in future as we move forward with this analysis. But, as was mentioned again in previous sessions, we know that naloxone has a short period of action. So it's not clear that it could be that the patient experienced a re-narcotization and required additional dosing at that time that they presented. So we had 15 cases that actually did receive naloxone in the pre-hospital and hospital setting. And again, you can see here, we're just kind of summarizing the table below that a lot of different forms of naloxone are being administered in the pre-hospital and in the hospital setting. So in conclusion of this preliminary data, we saw in this retrospective cohort study that we conducted in the preliminary data, it does suggest that there is quite a bit of significant morbidity that requires prolonged hospitalization and mortality, almost 16% associated with fentanyl overdoses in West Virginia. The amount of morbidity that we saw was much higher than previous studies have suggested. So earlier research prior to widespread availability of fentanyl had reported that among individuals that present to an emergency department for an overdose, only 11% required hospitalization. And you can see that that is much higher in this sample that we're from the data that we're showing you here today. And among the patients that present to the emergency department for a fentanyl overdose, they often require multiple doses of naloxone in attempts to reverse respiratory depression. So, you know, it's unclear, and this may be sort of a bias sample in the sense that, you know, individuals in the community who are able to successfully reverse a fentanyl overdose may never seek medical intervention. So this may be a sample that's biased towards a higher severity. And we also know that the pre-hospital setting naloxone data may not be consistently reported in the electronic medical record, so that's subjected to some challenges. And in West Virginia, we do face some unique challenges here that I think are across rural areas, and in particular in West Virginia. We know that individuals encounter stigma when they attempt to access naloxone in pharmacies, and not all of the pharmacies may sell it. So it's unclear at this point how over-the-counter naloxone will impact that, particularly in West Virginia. And I think part of that is contingent upon the extent to which over-the-counter naloxone will be available in other retail settings. So free naloxone, at least in West Virginia, is available on a very limited basis. And so we know that most of our community-based programs to the, you know, in the community, in our communities are actually distributing nasal naloxone, whereas harm reduction programs are more likely to be providing intramuscular naloxone. And so we know that among our patients who are in treatment for an opiate use disorder and being prescribed medications such as methadone or buprenorphine to treat their opiate use disorder, if they relapse to opioid use during treatment, we know that they're in a high risk of experiencing an opiate overdose and or overdose fatality. And so it's critical that they have access to naloxone. And we know that many of our patients are not accessing it. We do, without knowing the price point for the nasal over-the-counter, we're not sure if it's going to be affordable for low-income individuals, particularly in comparison to what the very low copay is right now for naloxone through West Virginia Medicaid. We know that, as I think you've heard this repeatedly, there seems to be a theme across the sessions, right, is that what's really critical right now is actually really timely access to the appropriate dosage and formulation of naloxone. And this is extra critical in rural areas, right? So we have a lot of parts of our state, and similar in other rural areas, where cell phone coverage is limited, spotty. And we even have areas that have actually no ambulance service. And that's really makes reversal of respiratory depression critical, and access to these products important. Current regulations actually require naloxone dispensing data to be reported in West Virginia's PDMP. And I think we need a lot of information in West Virginia. What we need more information on is how to manage overdoses that involve both opioids and methamphetamines, and also how to manage methamphetamine-induced psychosis. And finally, I just want to thank the team here at West Virginia University. This is really a team effort in conducting this research, and I wouldn't have the data if it weren't for these folks. So thank you very much for this opportunity.
What a great introduction on the concept of the real-world experience in treating overdose. Really appreciate you joining us, Dr. Winstanley, and we'll invite you back to the panel after our next presentation. So our second presenter is Alice Bell, who joins us from the Prevention Point Pittsburgh, where she serves as the Overdose Prevention Project Coordinator. Alice, we'd love to hear from you on your real-world experience before we get into the panel discussion. I'll step away and let you pick it up.
Okay, thank you. And it was fascinating to hear the speakers from the previous panel, and very interesting to hear the information from a experimental and clinical setting, and their speculation on how this would translate as to best practices in the community. And I really appreciate the opportunity to talk about what we've seen in real community settings. So prevention point is, let me see if I can actually advance this.
If you click and then hit the down arrow.
There we go. Yep. Prevention Point is a syringe service program providing safer drug use supplies since 1995. In 2005, we started distributing naloxone and training people how to reverse overdoses. In the early years, we had medical providers who volunteered to write individual prescriptions. Now, of course, we have standing orders that allow for a much broader distribution in the community. We primarily provide naloxone to people who use drugs at our service locations, but we also do some community trainings with families, librarians, treatment program staff. For years, we did training in the jail. And since the beginning, 2005, we've consistently collected data on overdose reversals reported by people who return for refills after having used naloxones that they obtained from us to save someone's life. That data that we've collected includes the number of doses used. And as I understand, we're one of the few sources in the country where data has been consistently collected over the past 18 years. One other data tidbit in there, just listening to the discussion about poly drug use, is that looking at our data, over 50% of the people who we've surveyed who are reporting overdose reversals report that they knowingly use a stimulant, cocaine or methadone, as well as opioids on a regular basis. So that's consistent. That would show up in a urine test or whatever, but that there's a high percentage of people who do use stimulants and opioids on purpose. So as of the end of 2022, close to 14,000 people have received naloxone through our program, and we've documented just under 6,000 reversals. In 2020, we launched a statewide naloxone mailing project in collaboration with Next Distro, mailing naloxone to an additional 14,000 people in the past 2 years, with 585 additional reversals reported throughout the state. We do not have access to point of service drug checking yet in Pittsburgh, so we've been reliant on death data from the county medical examiner. Our medical examiner is one of the best in terms of the testing, collecting, and reporting on detailed information on the drugs involved. So that has helped to give us a good picture of what's happened as fentanyl has increasingly supplanted heroin in the local drug supply. And we published a paper a few years ago where we compared the number of doses of naloxone that people reported using to reverse overdoses in 2013, when there was very little fentanyl. Only 3% of deaths in the county involved fentanyl, through 2016, when around 68% of deaths involved fentanyl. And we did not see an increase in the number of doses needed to reverse an overdose in the community. And in fact, we saw a little bit of a decrease in the number of doses used. Looking at the mean number of doses used, decreased from 1.62 in 2013 to 1.52 in 2016. In 2013, 89% of reversals used 1 or 2 doses of naloxone. And in 2016, 92% of reversals used 1 or 2 doses. So we saw, again, a decrease, somewhat of a decrease in the number of doses used. And we have always seen 1 or 2 doses as the standard. From the very beginning, we've seen in about 45% of the cases, people use 1 dose. In 45 to 50% of the cases, people use 2 doses, and then in a very small percentage, more than that. So we consider extra doses to be more than three or more. So by 2020, 95% of opioid overdose deaths involved fentanyl in Allegheny County. Still, we saw 91% of reversals using 1 or 2 doses of naloxone, and the mean number of doses remained at 1.52. In 2021, we saw a little bit of an increase, and then in the first half of 2022, that dropped again, with 89% reporting 1 or 2 doses, and again, the mean number of doses at 1.52. We have always asked people when they reported using more than 2 doses, some additional questions about why that happened, why they think that might be. The most common responses have been that they gave additional doses without waiting 3 to 5 minutes for the initial doses to work, and or there were other sedating drugs involved, like benzodiazepines, or more recently xylazine. So reports that the person was breathing but still unconscious or unresponsive. Or they found the person and didn't know how long they'd been out. I mean, this is the most common, one of the most common when we had deaths reported, where they found somebody that might have been not breathing for hours. And in those cases, sometimes people gave many doses. You know, we get occasional reports that they found someone, they gave them 10 doses, but they clearly had been already dead for some time. One of the things that we've speculated about, I mean, it's interesting to see that we saw a little bit of that we saw in 2013, we actually saw a little bit higher number of doses administered. In 2013, we were still giving out 10 dose vials of injectable naloxone. So, you know, kind of speculated that at that point, it was very easy for people to administer additional doses compared to the single dose vials that we have given out in more recent years. And then in 2021, when we saw a little bit of a increase in doses again, that was the year that we started getting free nasal Narcan from the state. And so we added that, give people the choice between both. And again, that's easier to use. Most people who report using multiple doses are giving nasal as opposed to the injectable. So this raises concerns for us about higher dose naloxone products coming on the market if people are already giving additional doses of naloxone because of just the ease of use. If we have a much higher dose, easy to use nasal spray that people might end up getting, 10, 20, 30 standard doses of naloxone all at once. So in the past few months, starting the third quarter of 2022, for the first time in all these years that we've been collecting data, we have seen an increase in the number of doses that people are reporting. 82%, a drop to 82% of reversals involved 1 or 2 doses, a higher number of people reporting using 4 doses or more. And this has coincided with increasing reports of what seems to be xylazine in the local drug supply. We're getting reports from people that the person started breathing again, but they were still out, they were still unconscious, and describing other aspects of the drug that sound like xylazine, reports of people passing out after doing a shot and waking up several hours later with no recollection of what happens. And so we have been very concerned about the higher dose products coming on the market. Most of the reports that we get are from somebody who used naloxone to reverse somebody else's overdose. But when we hear from people who report naloxone being used on them, we often hear reports of people saying that they don't like the 4 milligram nasal because it makes them really sick, and they ask for the standard intramuscular 0.4 milligram injectable. Some people say I like to have the nasal if I'm going to use it on somebody else because it's quick and easy. But if somebody's going to use it on me, I want them to use the injectable because it doesn't make me as sick. Sometimes, as has been discussed before, if 911 is called, people get additional doses. They may get additional doses in a hospital. So we are very pleased that one of the over-the-counter products looks like it's going to be a lower 3 milligram dose, that in cases where people are giving multiple doses unnecessarily, that at least they're not going to get socked with quite so much. I want to say that in 18 years, we have had no reports of someone dying because they didn't have enough doses of naloxone. In the past 2 years, we documented 1,569 overdose reversals. 11% of those cases, EMS was called to the scene. In 5% of those cases, people were hospitalized. Of the 23 reports that we got that a person died, in 18 cases, it was reported that they were found too late, that they might have been out even for hours. 3 cases, the paramedic told the lay respondents that there was another cause of death. Something else had caused their death, not an opioid overdose. In one case, unfortunately, a person said that the police would not let her use the naloxone she had, and the person died. And one case, there was no additional information reported. Just, stressing that we really see as critical that with the development of over-the-counter products, that there's a continued availability of inexpensive injectable naloxone. We offer both types to people now, and they can have their choice. About half of the doses requested continue to be for injectable. Pennsylvania spends millions of federal dollars on naloxone that would go so much further in purchasing inexpensive injectable product. We also have concern that the large amount of money that's being funneled into paying for nasal Narcan at this time may not always be there. And so we think it's really important we always teach everyone to use both nasal and intramuscular, so that if there's a time where we don't have access to free nasal Narcan from the state, that people will still have access to the cheaper injectable naloxone. I think that Dr. Winstanley discussed most of the pros and cons of OTC product. We're very happy to see that coming, and think that particularly in rural areas, it could be really important. We're looking forward to one of those products hopefully being the 3 milligram dose, and do have concerns about whether this will lead to reduced availability of intramuscular, and hoping that there'll be measures taken to assure that that isn't the case. Thank you.
Alice, thanks so much for sharing the real world experience. And as we pull our 3 panelists up on the microphone, I have a question to ask that we'll see if you have this information, but what's the rate of overdose reversal in 2013 versus more recently? And it's okay if you say, I don't have that.
I don't know what you mean, the rate.
So I think perhaps as you're thinking about, is it perhaps accessibility of the product and where?
Oh, yes. Yes. I mean, in 2013, we were the only place that lay people could get naloxone in Allegheny County. So it was exclusively for lay people, exclusively access to injectable naloxone, and only from Prevention Point. And at that point, we were doing it. It had to be done with individual prescriptions. So we had medical providers who came to the syringe service site and wrote out individual prescriptions for everybody that got it. Yeah.
Mm-hmm. Mm. So there's a minimum bit expansion of the availability.
Dramatic expansion
and use.
Very dramatic.
Okay. So we have our new panelists, and we'll go into robust discussion for about the next 45 minutes, which I'm so excited to have the honor to facilitate. So I'll first introduce our new faces on the screen. Let's welcome Ceci Blanchard, who works and organizes for Drug Users Health and Power with Community Access. We also have Dr. Justin Strickland, Assistant Professor with the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine. And rounding out our reactants is Dr. Zachary Desmond, a medical officer in the Division of Anesthesiology, Addiction Medicine, and Pain Medicine within FDA's Center for Drug Evaluation and Research. I first want to turn to our new voices, and Ceci, I'm going to turn to you first. Reflecting on what you've heard, how does that land with you and the harm reduction context that you work in? What do you want to make sure that we hear and think about?
Absolutely. Hi everyone. Apologies if my sound is a little wacky. I had to duck into a cafe. I'm out doing intakes for the day, so. But no, I mean, it's definitely all the information presented so far is, not at all how I'm approaching the work, like the doses, thinking about all of that for me. I'm really working from the person perspective. And I mean, for me, something I think that needs to be emphasized over and over in conversations about naloxone and overdose response is, the consequence. We're both saving someone's life, but we're also putting someone, if they have tolerance to opioids, into absolutely painful withdrawal. We never want to hesitate, when it comes to saving someone's life. But, I have seen people be maybe a little too trigger happy. And I think I'm very scared about, the kind of stuff. I've heard someone call it the naloxone arms race, to get higher and higher dosing, and I've gone through, horrible fentanyl withdrawal. And, I just think that needs to be part of the conversation. And, it's more than just, saving someone's life, but people are going to have to deal with the fallout from, once after their life is saved. I think also adding on to the conversation, I think discussion about oxygen and the provision of oxygen in response to overdoses is really important, and this kind of tags the element of, withdrawal. I did a lot of organizing work out of On Point, which is where, the nation's first 2 overdose prevention centers were. And really their go-to thing is providing oxygen to people. And, they've been able to reverse so many overdoses solely through the provision of oxygen. So I think we got to keep that in mind. And I think we, naloxone absolutely has its place and it saves so many lives. But I think we also have to make sure we have our menu of options, because at the end of the day, we have to be putting people's experiences and their comfort, at the center. That's my kind of initial thoughts.
Really helpful, Ceci, and thank you for taking time from what you do every day to join us. So no need to apologize for the background noise. We're just thrilled that you could invest your time with us. Dr. Strickland, I want to turn to you. You've done research on patient perceptions of higher dose naloxone. And how does what you've learned compare to what we've heard so far, including from what Ceci just shared?
Yeah, and first off, thanks for having me here today. It's a critically important topic, and I think the diverse voices bringing into this is super important. There's a couple of things, and including that, I think that's important to touch on after hearing the talks today. I think the first, and this is in line with what Ceci just mentioned, bringing in community-engaged medications development research, bringing in community into all of this medications development work that we do, because at the end of the day, we have this push and pull of the probabilistic risk of mortality when it comes to these overdose events, but also the probabilistic risk of that precipitated withdrawal that may turn off engagement in these products and engagement with these products. And to date, there's rather limited work engaging with the communities that might be using these products in the market and hearing those voices. So we've done a little bit of work both in community settings as well as within residential treatment settings. And some of that work, I think it reinforces both Dr. Winstanley and Ms. Bell's points in that there's support on both sides of some folks that are seeing a need, or at least a perceived need, of having these higher dose products, but also some folks that are very scared of these products and reluctant to use them. And anecdotally, and a lot of community engaged sites, reluctance to purchase these products for distribution for the reason of the folks that they're going to and that these products will be distributed to might have a reluctance of taking them. I think the other point, and I'm sure we'll bring up a lot of other things in discussion, we've talked a lot about dose today, and dose is extremely important, but the other extremely important piece in all this is the time to delivery, and the time at which naloxone is delivered to the person. And arguably even more important than dose is getting that dose to the person immediately and as fast as possible. And all the naloxone in the world is not going to reverse an overdose when it's not delivered when it needs to be. So I think in all these discussions of advancing products, and hopefully the good discussions we'll have the rest of today, we're also mindful of it's not just about getting a higher dose, it's also about engaging the community to have doses more readily available and making sure that the doses are delivered in a timely fashion. So kind of 2 quick points, and I'm sure we'll get to more.
That harkens back to Commissioner Califf's opening remarks, where he said we really have to be thinking about this in the deployment like we do the automatic external defibrillators. And is it available, and do people know what to do quickly? And then reminding us too of the slide in the last presentation where the time, I could just imagine the time ticking away on the 0 to 15 minutes across the x-axis there of how long those minutes must seem. And I think, Alice, you mentioned that you may quickly have a repeat dose just because it's a timely piece. Dr. Desmond, I want to turn to you as an emergency department physician and a regulator. Can we start with your clinical perspective, and how does your experience managing overdose in a Baltimore emergency department compare to what we've heard so far?
Well, thank you so much for giving me the opportunity to participate here and to give a bit of representation to the patients that I see in Baltimore. That being said, our story is very similar to what you've been hearing all day so far, in the arrival of fentanyl and the challenges that's brought along with it. To Dr. Califf's point, one of the things that I've felt a lot is that as a physician is that we need to start having, just like we have AEDs everywhere, we should have naloxone available there as well. It's an epidemiological risk, and it's just so common. Nobody really likes to talk about it. It's a condition that people are in some ways prejudiced against. And there's a number of different other factors that go into that, but it's something that's just so common. We should have it just about everywhere. And, probably tourniquets too, if I was going to say that my trauma colleagues. But in any case, I think another point here that we've been talking about again and again is having that community piece. We don't quite know how naloxone is being distributed, used, and there's that population that once they get revived, they don't go and see a physician like myself for a number of reasons, many of which can be very reasonable given a person's situation. But since we don't know that, we don't know how they're using it, how much they need, and with these changing substance use patterns, we need to be responsive to that. We've seen with fentanyl that as it's come through, we need to have new testing. We need to have widespread testing because it's not just a urban problem or just a Baltimore problem. It's getting to be an everywhere problem. And we need to be able to detect the problem, get our numbers, and then have that go through to how we can better treat our patients. And then along with that, how those communities are responding. Are they getting what they need? Are they not? And then having that feedback. And if synthetic cannabinoids and fentanyl, and there's always going to be something new on the horizon, and we need to start creating this feedback loop to make sure that we're treating patients and saving lives.
Really helpful and hearkening us back to, I appreciate you adding in the tourniquet for what we should have immediately accessible. I'll add that. I've already got the naloxone in the glove compartments for my cars. but now we'll know to add another one. But I think that is an important piece that we haven't talked much about here, is just the communication and understanding in the community about how and when and what to do in the situation where you believe you've have someone who is experiencing overdose. So I want to talk a little bit about that, and this is one where whoever's first to give me a hand raised or unmute, jump in here. But let's talk a little bit. I want to get a little more texture and discussion of experiences where someone had an overdose management product, so they have access to it, they have it on hand, but either weren't able to use it or it didn't work as expected. And I think, Alice, you gave us an example too on the slide, but I want to open it up. Are there others? Could we get a bit more discussion about that, where either weren't able to use it or it didn't perform as one would have expected? Betsy, fire away.
Yeah, I'd love to jump in here. So the situation, it was me. I was the one who was overdosing. I had just used, and the moment it hit, I like knew, I used the same dose that I usually do. And the moment it hit, I knew it felt different, and so, and this is something I've kind of learned, and that I do is I always, have one of my Suboxone strips on me, because I also take Suboxone, or I always, have them by my bedside or, nearby. And my first thing was like, I am not about to Narcan myself. Like, I just don't want it. Even though I have like a massive box of Narcan, right? I was in my bedroom and it's right, and my first thought was, I'm just going to take a Suboxone strip. And I took it, and kind of with the knowledge already in my head, that it can knock off some of the things, and what would usually be precipitated withdrawal. I took it, and it definitely helped. And I mean, I'm still here. I was by myself. I was still very intoxicated, but it definitely helped. And I was able, I was able to kind of reach out to someone who then came to be with me. And I mean, this is something that I preach 9 to 5 every day, how Suboxone, buprenorphine, I think is really an underutilized overdose prevention and overdose reversal tool potentially. There really isn't that much, like, I haven't seen any research kind of regarding that specific use the way I used it. But I do know, that the kind of layer it creates when you're taking it daily does have kind of this overdose preventative effect. And I mean, I definitely experience, because I take it every day, and besides that one, time, I've really been able to avoid a lot of, opioid related overdoses. And yeah, I really can't recommend it enough. And I've talked with my Suboxone prescriber, and she kind of explained to me traditionally, if a patient continues to use while being prescribed Suboxone, a lot of times the prescriber reads that as like, oh, this person is like not treatment adherent, or I don't know, maybe this just isn't the right thing for them. So like, let's just throw them back to the illicit market, like, and have them fare for themselves. Or they just are kind of like, very, I guess in a very not harm reduction way, or just like, we just got to stop, or like, just take the treatment, just take your medicine. And so knowing that, I mean, I think I, obviously push back on that. And I think combining those two of, if you're going to still taking your Suboxone every morning at the same time, and then, making sure to use like a little later on, and making sure to take the Suboxone before you use, has worked really well for me. So just want to throw that out there.
So Ceci, I think you're giving us an example where you used an alternative, and I think if I hear you correctly, was it in part because you were aware of and aware of what would happen if you used the straight naloxone.
Exactly. I did not want to go full naloxone. And yeah, but I had it like right on hand, but I chose not to.
Yeah. Other thoughts here and examples that folks want to share or contribute to the conversation?
I mean, this is from several years ago when I was doing a training in the jail, and a young guy came up to me and said that his mother had overdosed. And he said, she had a naloxone kit that she'd gotten from you guys at Prevention Point. And he said, I don't use any drugs. I've never injected anything. I had no idea how to use this. I didn't have time to read all the instructions. And so I said, what did you do? And he said, well, I took the cap off the vial and I put pulled up the liquid into the syringe and I jabbed it in her leg and she woke up. And I thought, for all the difficulty that we think about how, injecting somebody is so complicated. I mean, he figured it out. I said, you did it exactly right. The other thing that was an interesting thing was a woman who contacted me and said that she had gotten naloxone from us. And when her son overdosed and she needed to administer it to him, and she took the vial out and it was only a quarter full. And she thought that was, the bottle should have been totally full and she didn't have enough. And so she said, you should tell people, you should show people, this is how much is in it. This is one dose. So those are my examples.
Right. So about that communication and training, so that perhaps in first situation, more confident, in second situation, similarly more confident, but thankfully went ahead and administered without thinking it was.
And in terms of education, I mean, there others were talking about the importance of. Ceci was talking about oxygen, and I mean, one of the things that we've always over the years stressed is that you don't just hand somebody a naloxone kit, but you teach them how to do rescue breathing, you teach them to check people's breathing, all of that. And then with, as we're seeing xylazine in our local market, that's becoming more critical, that, don't just keep hitting them with naloxone, check to see if they've started breathing. If they're breathing, then they don't need more naloxone.
Yeah, so that training and education component. Thank you. Zachary, did you want to jump in there?
Oh, I was just going to say that, kind of touching on one of the other subjects that was presented earlier with regards to polysubstance abuse or multiple ingestions at once. There are a number of patients who will, sometimes they're in a medication-assisted treatment already and they want to hit a different receptor. And so they'll combine different other things like a benzodiazepine. And so they'll present as an overdose. They'll have signs of an opioid-specific toxidrome. We give them naloxone. They only get partial effect, maybe no effect. And it's a challenge. And on the other side of things, we'll also have folks, as also been described earlier today, where we have a rising incidence of stimulants being mixed in with opioids. And when those folks present again as a typical opioid overdose, we give them naloxone, we uncover the sympathomimetic, the very amped up, the patient becomes agitated, delirious. That becomes very challenging to manage because often they're not redirectable. And as much as it sounds backwards and it's intellectually frustrating, but we sometimes have to, for that person's safety and the safety of the staff, we have to then medicate that person with another sedative in order to make it so that it's safe for them. And it becomes, again, challenging to manage that airway and their respiratory status. And so as sort of like my public service announcement is in this conversation is, when folks are out there, they're using in the community and they have to administer naloxone, call 911 because we need to be able to see that person so that we can manage them. And if they are one of these atypical presentations, they'll be in a safe environment where that can get addressed.
Which is a great kind of a companion piece to, in the AED scenario where we have naloxone more widely available, the companion of calling 911 in a dynamic there if it's necessary. So you've led us to another kind of area we wanted to explore, which is to talk about strategies to adapt to the changing drug supply. We've heard for most of the meeting about the polysubstance use, the co-occurrence of fentanyl exposure with marijuana, with methamphetamines, with other components, with xylazine. How do you think about, so what do you think strategy-wise to adapt to that changing drug supply? Justin, you unmuted first, fire away.
Yeah, so and this kind of piggybacks on what we were getting to in just a moment ago. I think it's important from a general public perspective, the bystanders who might be reversing overdoses, who don't have significant experience with drugs or do not have significant education when it comes to drug-related effects, that the trainings that we're delivering to the public, the trainings that we're developing, describe these various profiles that a person might present with that may be atypical or may be different than what they're expecting in the context of an overdose reversal, and that it's not something to be scared of. It's not something that odds the possibility, and how to best manage those particular profiles of effects that might occur. For example, if you're reversing an opioid stimulant combination overdose and that stimulatory effect starts to emerge, that it's expectable, it's manageable, and skills to address that.
Mm-hmm. So another component of our education and discussion there in just preparing for that polysubstance dynamic. Ceci, please.
Yeah, so just to circle back to what Zachary said about calling 911, I think it's just to maybe add a little layer of nuance. I think we need to consider, your comfortability and expertise in terms of overdose response, and so maybe if you have no experience, that, because at the end of the day, we want to save someone's life. But me personally, because I have a lot of experience, I've reversed many overdoses. I personally do not call 911 unless the person is not responding to the naloxone, and I like to hold off until the person, is back with us. And if they're able to, communicate relatively quickly, I generally like to give them the option, because we know the police in the United States treat people very differently based on their class and race. And I used to be a journalist, and I was reporting on this instance up in Ithaca, where at a harm reduction program, a man overdosed. They responded. I guess they called EMS. Somehow that call got transferred over to the state troopers. The state troopers showed up. They ran his name. He had a warrant for shoplifting, and they arrested him while he was recovering from the overdose. So we got to be clear, 911 activates lots of people who are not our friends, do not have our best interests at heart. And then the second piece about, strategies responding to the ever changing, unpredictable illicit supply, we got to be clear, there's a reason it's always changing, and it's because of the war on drugs. It's not just a coincidence that things keep getting more and more potent. It's the more we clamp down, people, and the more border security, whatever it may be, people are going to find the more potent things that you need less volume to transport. It's the kind of framework that describes that is called the iron law of prohibition. And so for me, my, this discussion about, how do we respond to this? Are we going to just need to fund even more drug checking, which is definitely important. I think for me, the number one strategy is repeal the Controlled Substances Act. Let's actually get these things regulated so we won't have to even deal with the supply that's ever changing and unpredictable and, has rat poison in it or something, So that's really kind of where I stand. And there are lots of other kind of, micro interventions. One thing I will say about, in terms of the drug checking component in response to the ever-changing supply, something I've been talking about with some of the sciencey people is adding on a component to drug checking, it's called, there are different words for it, but like drug cleaning. So actual, because like once you realize there's some crazy stuff in your bag, you're like, okay, I'm not gonna throw this out. I already have like no money, just bought this stuff. I'm gonna do it. Maybe I'll take like a small hit or something. But I think it's really important, you know, to translate the really advanced chemistry into these, you know, and I feel like this is what harm reduction is so good at, translating these really advanced like distillation and separation. And I mean, on Reddit, these like Reddit nerds, you know, are really good at it and they figured this out. But I think the harm reduction movement needs to learn from that. And, you know, just like doing like distillation, recrystallization, all those different things, I think is really important because we need to be giving people options after they know, then making the bag actually safer for them.
So, Ceci, appreciate you reminding us of the broader context and the implications of different policies, different actions, and how each of us may view those differently based on our experiences and what the results are of different actions. Other thoughts on the changing drug supply? Alice, you unmuted.
Yeah, at first I wanted to say, you know, I absolutely agree with Ceci that what is killing people is an unregulated drug supply. That people, you know, don't know what's in their drugs, and even if they know, they don't have access to less dangerous formulations. I wanted to make my point. I wanted to go back to your original question where you asked about the rate of overdoses, just because I feel like it highlights how things have changed in a way and remained the same. In 2013, in Allegheny County, there were 229 opioid-involved overdose deaths, and we had reports of 225 reversals. In 2016, there were 600 opioid-involved overdose deaths, and we had reports of 446 reversals. In 2022, well, I'll say, yeah. So 2021, the preliminary numbers, it's probably more than this. There were 535. I'd say ultimately it'll be over 600 opioid-involved overdose deaths, and we had reports of 845 reversals. So the point of that is that I think that, even though we're seeing increased deaths that involve methamphetamine and cocaine, almost always they also involve fentanyl. Fentanyl is what's killing people. It's an opioid. Naloxone reverses it. We have seen, you know, I don't know. I mean, when people are talking about it in the medical settings, I mean, I know that sometimes people go to a hospital and die of an overdose, but I don't know what the percentage of that is. Certainly in the community setting, if people have naloxone, people live. There are very few. The only circumstances that we're really seeing where people don't live is if they don't get there soon enough, or there's some other extenuating circumstances. So I think that we have a really good tool. Could there be tweaks that make it, you know, better? But I think the more important thing is making sure that there's access to it. So I think that it begs the question of like community saturation with naloxone. In Pittsburgh, in Allegheny County, in Pittsburgh in particular, we've come a long way to having, you know, naloxone very available. We still are seeing way too many overdose deaths. We're seeing it primarily outside of the city in areas where there's less saturation, where there's less access to naloxone. With the Mail-In Project, we see in the rest of the state, there's much, much, much less access to naloxone. So I think that becomes the critical thing, is really not so much do we find the next type of naloxone or some other thing, but really using the tools, the effective tools that we have, and just making sure that it's really available to people. I agree also the importance of oxygen in those settings, but you know, and teaching people more information about that, but really, you know, just how do we get to community saturation with naloxone? How do we have it readily available whenever it's needed?
Which then could allow us to think about optimizing dosing and all of those things, but it doesn't matter if it wasn't there. Erin, did you want to say anything on keeping pace with supply or any of the components that we've been talking about here?
Yeah, I just wanted to add, I mean, you can see from what Alice has said and Sissy has said that, the importance of syringe service programs in delivering some more advanced education and sort of more than just distributing naloxone. And so again, from the rural perspective, we have pretty limited access to syringe service programs in the state. And even when they are available, they have limited hours of operation and people often have challenges in reaching them. So, really just trying to bring that voice forward. And, it really continues to break my heart that, the hesitancy among people who use drugs to seek medical services. And that's because of not just their treatment, as he mentioned, by the police, but also healthcare professionals that treat them as if their lives don't deserve to be saved. Right. So what's happened is, we've seen in all the presentations today that overdoses are becoming, because of the complicated and changing drug supply, they're becoming more medically complex and a little bit more difficult to manage in some areas. And yet we have individuals who are overdosing that don't want to seek medical care because of the way that they're treated. So I think we have to simultaneously, in West Virginia, when I said we're 20 years into this overdose epidemic, but yet stigma is continuing to be a problem. We really have to change the needle on this rapidly and understand that everyone's life deserves to be saved. This is not a moral judgment issue, and that they should be able to go into any healthcare facility, pharmacy, syringe exchange program, social service agency, faith-based organization, and get help. And when they say, I want help, and maybe that help is that they're not ready to stop using drugs today, but they just don't want to die. We need to open up avenues, and so that there's access to these resources and other things that are happening. So I really just think we've got to do something. This is really honestly a tragedy that's persisting to see the stigma that people are encountering.
It's Erin, you've stated it so eloquently. It reminds me in an earlier conversation related to naloxone distribution, a speaker noted that we've criminalized being human, and in this case, not yet being. We need to keep each person alive and continue to work with them and help the healthcare system better understand the dynamics here. We've got a couple of minutes left, and I want to make sure that we provide the opportunity if folks want to talk about naloxone dosing. We've kind of said a bit on let's optimize naloxone availability first. So let's put yes, want to optimize naloxone availability first. Do you have any thoughts about how then we might optimize naloxone dosing in the pre-hospital and hospital settings? And Justin, I don't know if this is some space where you've spent some time thinking about that, but we'll have to, so we'll put on the yes, access first, and now think through what should we be doing in the space of optimizing dosing?
Yeah, and I'm not sure whether it was, I think it was Ceci, but it might have been Alice who said this, of making sure that there is a wide availability of options. We've done some field work with community bystanders, and one of the things I was struck by was the sheer number of folks that preferred the intramuscular forms. I think we kind of went into that expecting a high preference for the intranasal forms, and we had availability of both high and low doses. And there was about a third of folks that came home with the intramuscular forms, and an intramuscular form. And anecdotally, some of that was, I already have an intranasal form on hand, and I can see situations where this intramuscular form is going to be handier, is going to be more important. I want a kind of diversity of options. And I think that speaks to a broader importance, a broader relevance of making sure, going back to my earlier point, we're going to the folks that are going to be on the receiving end of all of this, whether it's the community bystanders, whether it's folks that are using drugs and need it on hand, whether it's in that AED crash box available there. that we're not at the end of the day pigeonholing to a single product because we think pharmacologically it's best. There's a sociocultural context of all of this, and there is a context that involves, as we said, that push and pull of is it needed? Is it going to cause harm? Is it going to not be used? The best tool in the world that's not used is the worst tool in the world. So if we have this large availability of products as much as we can, I think OTC is going to be really important. As Alice said, I think it's good that it's a kind of a modular option, and that it's a relatively lower dose that doesn't necessitate the high dose if it's not needed. I do worry, not to get sidetracked a little bit on OTC, but on the notion of doses, that the availability of OTC blinds us to all the other products that are still going to be necessary, all the additional emphasis that's going to be needed on distribution, that we don't see OTC available over the counter and say all the work is done and the burden is on folks like Alice and others to continue distribution. So broadly speaking, having that cadre of options, I think, is really important.
Yeah, and Justin, really important to remind us that the elegant pharmaceutical solution that's not the mechanism of choice for the patient is elegant and useless in that situation. And so an array of options can be more helpful. Erin, I saw you unmuted.
Yeah, I was just going to dovetail. I think the patient choice is really critical, right? So that we see 50% wanting nasal or intramuscular. But I think, at least in the rural areas where we have high-risk individuals that are not very close to emergency medical centers or ambulances or syringe exchange programs, that really trying to increase education about intramuscular naloxone is being critical for those high-risk populations. I think we saw this presented in the data presented earlier today, and looking at the bioavailability of nasal naloxone, that there really needs to be increased efforts in pockets of the country, these rural areas where they're not easy access to. I'm only 70 miles from Pittsburgh, right? But that's pretty difficult for low-income people who can't drive. They don't have a vehicle, they can't get up there, and it's not feasible for them. So really, I think, folks in rural areas thinks that there are people who think that naloxone cannot reverse a fentanyl overdose. And, I think it's, what Alice mentioned in her presentation, right? Very few needed multiple doses when they were using the intramuscular formulation. And so I think that's a critical component to keep in mind here. And considering the efficacy, and not to mention what Alice said too, right? So the affordability. So when you're in a state like West Virginia, where there are extremely limited financial resources available, that we really need to consider that economic argument that Alice had presented.
Mm-hmm. And Alice, I saw you unmute.
Yeah, I also the one thing about intramuscular naloxone is that it's, I guess the word is titratable, is that people, so, we have had, so in the circumstance where Ceci described overdosing herself and not wanting to go full Narcan, that, if you have a vial of naloxone, and I'm sure Ceci knows this, maybe that wasn't, didn't seem like the right option or wasn't available, but, you can give yourself half a dose or a quarter dose of naloxone. That is something that people have done. I've also had people who told me that, there's somebody in their family or their, that they, live with it, that is, very, very concerned about getting into severe withdrawal, and that they would use, one dose. If they needed more than that, they'd use an additional half a dose instead of a full second dose. So there is that ability for people who are good at it, who know what they're doing. I mean, I see people who are, come in and they say, I've been reversing overdoses for years. I reversed 40, 50 overdoses. And I know what I'm doing. I do rescue breathing, and I give a small amount, and then I give a little bit more, and then I give a little bit more. And I think that, with most medications, that's how we do things. When you have ibuprofen, they tell you take one. If it's not enough, take two. they don't say, they don't say, we will give you the 800 milligram that has to be prescribed for everybody. That we start with a lesser amount and go more. And I understand the discussion about that, you reach a higher level if you give more immediately, but I don't know that that's necessary. I mean, we're not seeing people who are getting 2 doses of injectable naloxone and they're dying because they didn't get enough. It sounds like the issues have to do how quickly they get it and that sort of thing, but that's not what we're seeing. And I also, one of the presenters and one of the other panels talked about in the community, people not being good about reversing, dealing with withdrawal symptoms.
Mm.
In the community, in my experience, people are careful to try to avoid putting somebody into severe withdrawal so that they're not getting, they're not making the person really miserable and they're not getting puked all over as well. But so I think people do know how to manage it and they know how to avoid it also.
So an important, right, one of the things we've heard throughout today's workshop is the way we view things based on that kind of perspective of where we are, different ability to navigate those and thinking through how, if you have a lot of experience with the product, how to better use it in what you'd be watching for. Any other thoughts of folks who want to chime in here on dosing? And if not, we have just enough time for a final question where I will put to each of you if there's one thing that you could do in the overdose reversal space, what would it be? And Ceci, you get a second one because I already heard your first one about the Controlled Substances Act, but we'll give you a second one. But I'll ask the question one more time, and that's briefly, if there were one thing that you could do in the overdose reversal space, what would it be? Ceci, you unmuted. You get to go first.
I don't know if this is the same as repealing the Controlled Substances Act, but it'd just be safe supply.
Safe supply. Yep, that makes a lot of sense. Thanks, Ceci. You're all so anxious to answer this question. There we go, Erin, far away, and then
free access to naloxone across the country via the mail, via every location, in any formulation or dosage that people choose to have it.
Mm-hmm. So broader accessibility and understanding, I bet, right? Understanding and how to use it. Dr. Desmond.
Just adding on to the same, wider accessibility. And with that will come some destigmatization because it'll be everywhere. And, again, it needs to be right there along with every other rescue device that we have to make it as available as widely as possible. Because this is as there is some forces against it, or there's prejudice against it. It's something that touches on everybody's life. We all have a brother, sister, father, son that deals with this problem, and we just need to address it and accept that.
Mm-hmm. And it can be small steps and just understanding and having the conversation and thinking through it. It did. I will say that my efforts to make my new hostess gift naloxone has stimulated some really interesting conversations with the folks to whom I aspire to provide it. But if we can make small steps like that, I'm going to do Justin, and then Alice will give you the final word. Dr.
I got
Strickland.
to hang out and hear everyone else's answers before I had to give an answer. The accessibility piece. So I think, and beyond cost, there's also and beyond having it kind of in the crash box, having it next to ibuprofen not necessarily next to ibuprofen, but you can pick it up at CVS, you can pick it up at 7-Eleven, you can pick it up anywhere instead of having to go roundabout ways. On an earlier call, we were talking about, I think it was Alice mentioned the sheer number of hours that staff go into to get free access. It's when it's not around the corner, it's hard to get.
Yeah. So, more outlets and availability there. Alice, final word, and then I'll close us out for today.
I would say that at this point, we are not going to really address the problem of overdose deaths without safe, regulated drug market. Short of that, cheap, injectable naloxone available over the counter.
And so the super helpful. And Alice, I think you might have said have one over the counter and one prescription. You want cheap injectable over the counter. I want to make sure I get it right.
Cheap injectable available over the counter. Yes.
Got it.
Yes.
Got it. Then
in addition to other formulations available over the counter that making the injectable available OTC would make it a cheap product that would be much more accessible to people.
Yep.
And over the counter would reduce the other barriers.
All right. Thank you for that. And with that, I want to say, I know that everyone who's in the workshop is thanking each of you for investing your time and sharing your real world experience and insight with us today. I want to thank everyone who joined us for part of their day to talk with us, and we will have 4 more hours of discussion tomorrow. So if you're available, we would welcome to have folks come back tomorrow to discuss the gaps and opportunities for drug development, as well as optimizing treatment of opioid-involved overdose with existing reversal drugs. The recording and other materials will be posted on the website next week. And as noted earlier, the slides are already there, so you can look at those. With that, everyone, thank you so much. Have a great rest of your day, and we will hope to see many of you at our workshop in day 2. Take care.